पंखा चलाना।
We are live, sir.
Good evening, friends. Welcome to the collaboration between Indian Arthroscopy Society and Punjab Orthopaedic Association. It's an excellent platform today where we have our budding surgeons from Punjab joining in, along with panelists which are comprising of senior people like Dr. Manish Dhillon and Dr. Ravi Gupta, putting up an entire program about controversial issues in shoulder injuries, especially rotator cuff, stiff shoulder, and traumatic fractures of the shoulder. We're going to talk about Enigma of the partial rotator cuff tears, mini open versus an arthroscopic rotator cuff tear, neglected rehab after a massive cuff tears, and controversial issues like rotator cuff tears with frozen shoulders and capsular release, whether it works or not. Also, four-part fracture dislocations and the consensus on latest about suprascapular nerve block and subacromial injection. So this is a whole lot of program which has been actually set up by Dr. Siddharth, who has worked out a program. The faculty today comprises of Dr. Manish Bansal, Dr. Nitin, Dr. Dilbans Pandher, Dr. Mukul Kaushal, Dr. Inderdeep Singh, Professor Rajnish Garg, Dr. Sharad Prabhakar, and Manit Arora. So I think these guys are one who are doing a lot of work now in Punjab, especially on shoulder arthroscopy, shoulder trauma. And it would be nice for us to listen to what is latest happening. I must thank Dr. Samantha, Secretary of Indian Arthroscopic Society, who has been actively collaborating with various state chapters. And among them, Punjab was one which we had been trying to tie up from a long time, because a lot of upcoming good work is being done now in Punjab. So I think we must thank Punjab Orthopaedic Association for collaborating with us. A special thanks to Dr. Sudhir Garg. Dr. Sudhir Garg is president of the POA, and Dr. Aggarwal, secretary of POA. Both these guys have been flag bearers of Punjab Orthopaedic Association and have brought this society and association to a new height. Dr. Samantha, if you can welcome Dr. Sudhir Garg, Dr. Hariom, and entire faculty. And
yes,
then
yes.
we can have some words from the president of POA and secretary of POA. And then Siddharth can then run the program along with Dr. Ravi Gupta and Dr. Manish Dhillon, the way he wants the whole program to.
This is a great honor. I just bow down all my regards from Kolkata, and also as being the secretary of the association, I've really been honored that the president and secretary of Punjab Orthopaedic Association, they have taken our invitation, and Siddharth in long been friend since long. So, IPS is the boss of my team. So we are trying to organize the program with all the states throughout the country so that the arthroscopy is been accessible to most of the people. The juniors are been taking the membership, and also they get training. So I request the president and secretary of the Punjab Orthopaedic Association. Also, it is a great honor that I have been there with one good friend, Ravi Gupta sir, and also Mandip sir is also will be joining for the program. So I welcome you all, and the kind words from the president and secretary of the POA. Then it will be taken away by Siddharth and the moderators, and then we'll go ahead with the scientific program. So I'll welcome our president and secretary for the welcome message to the faculty. Then we'll go ahead with the scientific program. Thank you, sir.
Thank you, sir, for your kind words. And it is our pleasure on behalf of the Punjab Orthopaedic Association. It's a pleasure to be associated with the Indian Arthroscopy Society for this program. And with such an outstanding faculty, I'm sure it's going to be a wonderful program and very informative. Thank you, sir.
Thank you, sir. Aggarwal, sir.
Thank you, sir. Sir, thank you very much for giving the Punjab Orthopaedic Association this opportunity. Actually, a lot of work is being done by the guys in the Punjab Orthopaedic Association, and we are thankful to the Indian Orthopaedic Association to project the Punjab Orthopaedic Surgeon at this platform. We are really thankful to the Indian Orthopaedic Association for giving us opportunity to show our work over this platform. Thank you very much.
Thank you, sir. So I think Siddharth and Ravi Gupta sir and Rajnish, they will take care of the scientific program. Okay, IPS, we can go ahead with the scientific session.
Yeah, so absolutely. We can have welcome words from Dr. Ravi Gupta, Professor
Orthopaedic. Yes, Ravi Gupta sir is also joined. Yeah, Ravi Gupta sir, please.
Yeah, sir. Good evening to all of you. And
It's a privilege for Punjab Orthopaedic Association that we are holding this webinar. The efforts mainly of youngsters. All credit goes to Siddharth. He has done a lot of hard work, and we are thankful to Punjab Orthopaedic Association who have collaborated. So I think the program is very well made, and it's going to be of immense help to all of us. So thank you.
Thank you, Professor Ravi. So Siddharth, you can take care of the scientific issues now.
Yeah. Good afternoon, sir. Thank you for all for joining and sparing your time. And let's try to make this event a success. I am extremely happy to be sharing the platform with my teachers, Dr. Ravi Gupta and Dr. Sudhir Garg, because of whom today I am at this level that I am doing some sort of scopy. Otherwise, I would have been lost in the sea of orthopedics. I am really grateful to my teachers and my seniors and friends, Dr. IPS Oberoi, Dr. Samantha, Dr. Rajnish, for guiding me to this level. And starting on with today's program, we'll have 8 topics. We'll have a short topic and a discussion along with. All of these are relatively controversial, or you can say the dilemmatic issues in which we are not clear. So let's hope for a fruitful discussion. Starting on with the first topic, rotator cuff tears and enigma. We have Dr. Manish Bansal from Jalandhar, who is an outstanding surgeon. And I would invite him to start his talk. Dr. Manish, please.
Thank you, Siddharth, for inviting me for this talk. Can you hear me?
Yes, sir, we can.
Okay, right. So I'll start with my talk, which is, I don't think, such a controversial talk to start with.
Share a screen, sir.
Sorry, can you not see the screen? Sorry, let me.
No, sir.
Wait. Sorry, I will. Just give me a sec. Can you see the screen now?
Yes, sir.
Yes, yes.
Right. So my topic is, I'll say, not so controversial or controversial rotator cuff tears. Is it an enigma? Enigma in the sense that we do not pick up rotator cuff tears as frequently as we should as orthopedic surgeons. Most of the shoulders which come to us or walk through in our doors are frozen shoulders. So shoulder itself is an enigma. The only word most surgeons use is frozen shoulder. Hence, rotator cuff tears is an enigma. So I'll try to solve that for you today and see what are rotator cuff tears and how we can pick up. So introduction is that we knew about rotator cuff tears as long as more than 200 years ago when it was described by Monro. Subsequently, many other surgeons, authors have described in great detail about rotator cuff tears. Neer in 1972 coined the term impingement syndrome and described in great detail about the cuff tears. So obviously, everything starts with anatomy. We should know the anatomy of the shoulder. What is rotator cuff tear? What is a rotator cuff to start with? Rotator cuff consists of 4 muscles, which start from scapula and insert at humeral tuberosities. Anteriorly is subscapularis, superiorly is supraspinatus, and posteriorly infraspinatus and teres minor. So these are the muscles which make the rotator cuff. The long head of biceps is considered a functional part of the rotator cuff. It helps to compress the humeral head into the glenoid. It also guides the head of the humerus as it is elevated. The bicipital groove traveling on the biceps tendon like a monorail on its track. So we know about the coracoacromial arch. So shoulder is essentially a story of 2 concentric circles. We also know that acromion type 2 and 3, Biglani has described type 1, 2, and 3, and 2 and 3 are associated with rotator cuff tears. But we are still not sure whether these are the rotator cuff tear is a result of type 2 or 3 acromion, or type 2, 3 acromion is an effect of a rotator cuff tear in first place. So the function of the rotator cuff, it rotates the humerus with respect to scapula. Most importantly, it compresses the humeral head into the glenoid fossa, thus providing a critical stabilizing mechanism to shoulder called concavity compression. It also provides the muscular balance for the shoulder. So in this picture, you can see that the subscapularis in the front and infraspinatus in the back form a force couple which compresses the humeral head into the glenoid, helping the deltoid and the supraspinatus to act and elevate the shoulder. So that is concavity compression. Coming to the rotator cuff tears. The incidence of rotator cuff tear increases after the age of 40 years. And that is the age when we see frozen shoulder, mainly around 40, 50 years of age. Hence the problem between rotator cuff tear, distinguishing between rotator cuff tear and frozen shoulder. Usually there is no history of trauma in both of them. Rotator cuff tear usually start with one shoulder and subsequently the other shoulder gets involved. 40% of the patients with rotator cuff tear have never done any strenuous tendon and extends outwards. The prevalence of rotator cuff disease increases with age. 4% of asymptomatic patients are aged less than 40 years. And 54% of patients aged 60 years or over have partial or complete tears of the cuff on MRI. So as much as half the people after 60 years will have a MRI proven rotator cuff tear. On ultrasound scan, it has been shown that 13% of the population in the 5th decade will have cuff tear, 20% in the 6th decade, and 31% in the 7th decade of their life will have a rotator cuff tear on ultrasound. Mind it, MRI will pick up a much higher rate. So what happens? Why the rotator cuff happens? The pathogenesis says that the cause of rotator cuff usually is a tendon degeneration. It happens with aging. First of all, there is change in the cellular arrangement in the tendon. There is calcium deposit, fibrinoid thickening. There is fatty degeneration, necrosis, and ultimately a rent of the tendon. Fiber failure has 4 effects. It increases the load on the neighboring fibers called zipper effect. It detaches the muscle fiber from the bone. It compromises the blood supply to tendon fibers and exposes the tendon to the joint fluid. So this is how the tendon tear starts. So part of the tendon is torn and there is increased forces or pressure acting on the remaining fibers, which tend to give way. So the anterior leading edge of the supraspinatus is usually the place where the rotator cuff tear starts. It starts on the deep surface of the tendon and gradually the cuff tear progresses in size. So the natural history of the rotator cuff tear has been described by Neer in 3 stages. Stage 1 occurs in younger patient less than 25 years of age. There is edema and hemorrhage of the tendon and bursa. Stage 2 involves tendinitis and fibrosis of the tendon and is seen in 25 to 40 years of age. And stage 3 involves tearing of the rotator cuff. Could be partial tear or could be a full thickness tear and occurs in patients older than 40 years of age. Yamanaka demonstrated that only 20% of the tears will either heal on their own or they'll become smaller in size. 80% of the tears will propagate in size or partial thickness tears will become full thickness tears. So mind it, 80% of tears will progress with time. Full thickness rotator cuff tears do not heal spontaneously and may progress with time. This has been demonstrated by multiple authors like Yamaguchi, Weber, Fukuda in their respective papers. A number of patients will develop an irreparable rotator cuff tear due to progression of the tear and tendon retraction. Some patients will go on to develop a secondary degenerative change of the glenohumeral joint, which is termed as rotator cuff arthropathy. Many authors have tried to describe or classify the rotator cuff tears. Matheson gave his classification in 98, depending on the site and size of the tear. Then Cofield gave his classification in 82, depending on the size of the tear. Less than 1 centimeter is small, 1 to 3 is medium, large tear is 3 to 5, and massive tear is more than 5 centimeters. Pate gave his classification depending on the stump of the tear. Then Allman and Gartzman gave their classification in 1993, depending on the shape of the rotator cuff tear, whether it's crescent shaped, reverse L-shaped, trapezoid, or massive full thickness tear. And Snyder gave his classification in 2003. Where is the location of the tear? It's articular surface, bursal surface tear, or a complete tear. So coming to the clinical presentation, degenerative rotator cuff tears tend to occur in older patients around 50 years of age and often have no history of trauma. They present with progressive shoulder pain and dysfunction. Exactly the same symptoms as a rotator cuff, as a frozen shoulder patient. So the common symptoms are stiffness, especially the internal rotation, pain, which is usually worse at night time. There is weakness of the shoulder, and there may or may not be instability of the shoulder. The examination has to proceed in the following way. It may reveal that there is some muscle atrophy around the shoulder girdle. The range of movement should be assessed. And this is where you'll differentiate between a frozen shoulder and a rotator cuff tear, because rotator cuff tear will have generally full passive range of motion, while the active movement may be limited. In frozen shoulder, both active and passive range of motion will be restricted. If patient has passive range of motion, then it's unlikely that they are frozen. Knee signs and Hawkins signs can be useful for assessment of impingement. Then specific muscles can be tested. Specific muscles of the rotator cuff can be tested by the specific tests like hornball blower sign, Job's test, and Gerber's belly press test. The common signs that you'll pick up on examining the shoulder: there will be tenderness over the subacromial space. There will be a decreased range of motion, the weakness of specific muscle testing, and positive impingement signs. Then we investigate to solve this problem. The investigations always start with X-ray, which can be an AP, an axial, or an outlet view. They tell us about the acromial-humeral space, acromial morphology, glenohumeral joint, and other bony landmarks of the shoulder joint. Then ultrasound, which is a very good technique to pick up rotator cuff tears, but it is operator dependent. The advantage of ultrasound is that it is dynamic in nature. So you can actually see the rotator cuff move with the movements of the shoulder. The gold standard for rotator cuff tear these days is MRI. Most of the tears will be picked up on MRI, and further management can be planned depending on the size, site, morphology of the tear on the MRI. Differential diagnosis, the first and foremost is frozen shoulder. In my practice, out of all the shoulder patients that come to me, I think only 10 to 15% patients tend to be frozen shoulders. Rest of them tend to have some other problems. For example, tendonitis or bursitis, cervical radiculopathy, AC joint arthritis, or osteoarthritis. But vast majority tend to be a rotator cuff tear patient. Treatment, which will be talked in great detail in subsequent lectures. The aim is managing a rotator cuff tear is to reduce pain and improve function. The evidence for conservative management of a rotator cuff tear indicates or dictates that initially conservative management should be tried for 6 weeks to 3 months, unless there is an evidence of acute tear in a younger patient. If you have a young patient who has an acute traumatic tear, then you have to go in for surgery. In an elderly patient with a rotator cuff tear, you can try conservative management for 6 weeks to 3 months. Conservative management includes analgesia, anti-inflammatory medications, physical therapy, activity modification, and subacromial injections of local anesthetic with or without steroid. But prolonged conservative management in symptomatic patients can have negative consequences. These negative consequences include that the cuff tear will increase in size. Tear will retract away from its footprint. There will be increased difficulty of repair, and there will be muscle atrophy with fatty infiltration. Such kind of muscles do not heal even after a rotator cuff repair. All of this can result in a diminished outcome. So if the patient tends to be symptomatic after conservative management and is not improving, then surgical management should be considered. Multiple injections should be avoided, especially if there is a diagnosed rotator cuff tear that is potentially repairable, because multiple steroid injections make the quality of the rotator cuff tear worse. Repair of a torn tendon cuff has been shown to give predictable pain relief and functional outcome with good overall patient satisfaction. The results of open, mini open, and arthroscopic rotator cuffs have been favorable and comparable. Though a very high re-rupture rate of 13 to 68% have been reported after rotator cuff tear, but multiple studies have shown that patients suffering a re-rupture still have significant improvement in pain and function. Though your patient may have a re-tear after surgery after a few years, but they'll continue to have better results than patient who did not have a rotator cuff repair in first place. So rotator cuff repair can be done either arthroscopically or mini open. Despite the risk of complications and tendon re-rupture, rotator cuff repair predictably reduces pain and improves function, strength, and function in symptomatic patients. A recent systemic review by Lindley and Jones found no statistical significance difference in post-operative outcome or re-ruptures, whether patient was done arthroscopically versus mini-open. So mini-open and arthroscopically results are comparable. These are some of the diagrams showing how the cuff repair can be done. It can be done by a single row repair or a double row repair. So in conclusion, a rotator cuff tear is a degenerative process. It is part of normal aging. It is underdiagnosed and undertreated in India. If left alone, it does not heal on its own and increases in size. If still symptomatic after a trial of conservative management, then there is a role of surgical repair. Rotator cuff repair predictably reduces pain, improves strength and function in symptomatic patients. Thank you.
Thank you, Dr. Manish, for giving a overall brief picture about the rotator cuff onset, progression, and the management issues. Now we'll address one of the each issues in detail. I think, do we have any questions for this thing, sir? Dr. Ravi Gupta, as a panelist, sir, your comments and sir, Dr. Ravi.
Ravi, you need to unmute yourself.
Yeah. Can you hear me?
Yes, sir, please. We can hear.
I think it was an excellent presentation. I just want to add one thing, like we are now more of a seeing patients from sports people. So literature, especially the orthopedic literature, mostly talks about the degenerative part of the rotator cuff disease. But I would say that the patients who come with, after a incidence of sudden jerk or sudden injury, sudden fall, rotator cuff tear, young people, we should not think about conservative in those patients because it's their carrier. So in those cases, the surgery should be the first line of treatment. While in degenerative tears, the surgery should be taken with a lot of pinch of salt because the re-rupture rate is also higher in degenerative tears. The healing rate is higher in traumatic tear in younger people. So this is just, I want to make a comment. Otherwise, it's an excellent lecture. Yeah.
Ravi Gupta sir, मेरा एक question है because in front of this big forum, I want to clear one of my doubts. Because this has now been in our shoulder group. This is a big question in the shoulder society now. Whether in cuff tear, you give one sort of steroid injection. And if you give, then what should be the minimum waiting period for your surgery? So I want to have the opinion of the senior most people like you and my friend Rajnish.
Yeah.
And IPS too. Obviously, IPS is there.
Actually, they are two entirely different conditions. In cuff tear, if you are talking about primarily cuff tear only, the cause of the pain is impingement. These people usually won't get the classical night pain, which is a more of a sympathetic or parasympathetic, kind of a phenomena that is in the frozen shoulder. So the injection into subacromial space, if I give ever in rotator cuff tear, mostly I want to see, it's a kind of a diagnostic test that with lignocaine, if the pain vanishes immediately after the subacromial pain, so it's coming from the subacromial space. But there are some cases who have both the elements. They have tear, degenerative tear, as Dr. Bansal has mentioned to us that if you get the MRI of people above 55 years or 50 years, many of them, they will show tears without any symptoms also. So many a times the tear is visible in MRI because now there is a trend that the patient with shoulder pain comes to you in the OPD with MRI in the hand. So the MRI has already mentioned the tear, but actually there's the pathology of the frozen shoulder.
No, Ravi Gupta sir, my question is, suppose you see a MRI, there is a cuff tear, and whether it is full thickness cuff tear, whether if it is a traumatic tear, and the patient is painful, whether you are going to give injection, yes or no?
If it is purely cuff tear, no role of injection.
Yes, IPS?
In my hand.
So yes, Samantha, if it is a traumatic cuff tear, there is no role of injection. But then there are a group of patients which have got a chronic cuff tear, but they come as painful shoulder. definitely one injection can be tried as a part of conservative therapy. But it is a proven case of a traumatic cuff tear. There probably, as Ravi rightly said, there is no role of any injection in a traumatic cuff tear. But in a painful chronic shoulder, probably if maybe a cuff tear is incidental, as Ravi said, on an MRI you might find cuff tear, and patient is symptomatic, and symptom mainly is a pain. You may actually go ahead and give one injection.
One shot.
That's a part of conservative. One shot. That's a part of conservative therapy. That's a part of conservative.
Sharad is there. Sharad is waiting. Yeah.
You give it some.
Sharad, please.
Raise the hand.
Sir, I definitely agree with Dr. Ravi, Dr. IPS. Just one comment that I would probably defer my surgery for about 10 to 12 weeks if I've given steroid in the shoulder rather than picking up surgery immediately. I'd just like to raise another point that about progression of cuff tears. So partial tears progress less than a full thickness tear. So for example, this was a study by Keener in 2015, published it in JBJS. So 2-year progression of a partial cuff tear was 11%, 5-year would be 35%. And similarly, large cuff tear, 2-year would be 22%, whereas 5-year would be 50%. Yeah. So definitely a complete full thickness tear, definitely go to higher chance of progression as compared to a smaller tear. Just my two cents.
So here I want to give another clarification. Like if a sports person comes to you, because we get a lot of sports persons in Chandigarh who already have got an injection from periphery. So I don't wait for 10 to 12 years in those cases. Suppose he had an injection yesterday, he is a national player, and I know that it's a full thickness tear which can affect his career. I will operate the next day. So there I will not wait.
No, Ravi, the confusion is that because there are a lot many literatures there, if you give one injection, you have to wait for 6 months. Because if you operate this thing, your re-tear rate is between 18% to 40%. So that's
but Samantha, there are two types of literature with us. One is orthopedic literature. The other is the sports medicine literature. If you look at the most of the sports injury journals, so they will be a little more aggressive towards treating them.
Yeah.
So because it's the career of the player is at stake.
Yeah, I think Nitin has raised the hand. Nitin, you want to ask a question?
Hi. No, I just want to have a comment on that, if it is okay with the faculty.
No, Nitin,
go ahead.
Okay. Dr. Samantha, regarding your question, in chronic, like Dr. IPS and everyone said, Dr. Ravi also said, Dr. Sharad also said, in acute traumatic tear, there should be no role of injection. Yes. There are two very good studies. One is that it increases the re-tear because it decreases the quality of the cuff. Number one. Number two, which is again a JBJ study, it shows that after a subacromial injection, when you do a cuff repair, the chances of infection, post-operative infection, it is more in these cases as compared to a virgin shoulder. So in my practice and otherwise also, I think the acute traumatic tear should not get an injection. By chance, if the injection is given, I think there is no harm waiting for 6 weeks, irrespective of the profile of the patient. This is my take on that. Thank you.
Okay, Rajnish, you are muted. Rajnish, you are muted yourself. Rajnish, you have to unmute yourself. Professor Garg.
Yes, similarly, like everyone said, if I want to operate upon a patient, if it is a younger patient and it is a traumatic tear, and I am planning to operate upon that patient, then I will never give an injection usually. And if it is a degenerative patient, tear and an old patient where patient is having a lot of pain and there is no proposal for the surgery, then we can go ahead and give one injection.
Okay. So thank you.
If I put it in a perspective, so it says that injection definitely we need to wait, but the waiting time rather than being 6 to 12 months, we can cut it short, especially if the patient is high demanding and young. That is close to 6 to 8 weeks or 6 to 12 weeks is the time. And the threshold should be to operate early in a younger patient who is more active rather than an elder patient. Elder patient waiting is probably a better option in view of the re-tear rates and maybe.
Can I ask another question here to all the panelists? Many times I get patients who have injection from outside and they have sling also. Since I am not waiting, so I am operating and I have not done an organized study that whether they are, how many % of them they are failing in kind of healing or not. I think it's a good topic to do a research. But how many of you recommend that you will restrict some activities in there's a full thickness tear, you don't want it to progress in the next 6 weeks or 12 weeks till you are giving this in, waiting for the injection to wean off? Do you give some kind of protection?
No. It is not. No way we are giving any sort of bag or pouch or whatever. Unless if the pain is the only indicator, probably sometimes you can give some pouch and all this, because if you give the pouch, the patient will be stiff and then they'll be very hard to operate.
Again, this point is this is controversial. This thing, if it is a complete tear, so there is a controversy whether the patient should be given rehabilitation or physiotherapy, or should he be given rest. So that is also a point of controversy. But normally, like, we should avoid the strenuous or aggressive rehabilitation with a complete tear, so that the chances of tear will increase. The progression of, I think, normally we go for a.
I think that is true. I think getting the joint flexible, capsular stretches, these are all allowed, and they are actually recommended even if there is a cuff tear. You don't want a stiff shoulder to happen. But at the same time, aggressive rehab should be avoided. It has got a tendency to progress the tear. That's true, I think.
Okay.
That's the reason for a arm pouch for some time. Yes, Siddharth, I think we can continue with the next
one. Yeah. Sir, I think the next talk is on partial cuff tears, and I think we have a subset of patients who present stiffness along with that. So Dr. Nitin Bither, esteemed friend, will continue with this talk. Nitin, please share your screen. Nitin?
Hi, I'll be sharing my screen. Just a minute. Can you see my screen now?
We can see your screen, Nitin.
Okay.
Yeah, full screen. You can continue now.
Okay. Good afternoon, everyone. I will first like to thanks IAS and Punjab Orthopaedic Association to give me a chance to speak on rather, I'll say, a controversial topic, partial rotator cuff tears. So Dr. Manish spoke on rotator cuff tears, and he actually, during his talk, like, there were few comments he made which were in actual controversial comments. Like he said, most of the patients, they are coming with a diagnosis of frozen shoulder, most of the patients. And in a rotator cuff tear, you expect a full range of motion. Yes, a full thickness rotator cuff tear usually do not stiffen up. If we stiffen them up, then it is all right. Otherwise, partial rotator cuff tears, they can actually mimic a frozen shoulder. So there is a spectrum of disease we see in our OPD practice. That spectrum of disease is the rotator cuff disease. So shoulder is the third most common cause of pain after back pain and a knee pain, which we see in our OPDs. And once a patient presents with a shoulder pain, mostly the diagnosis is frozen shoulder, but underlying, I think most of the diagnosis depends on a spectrum of rotator cuff disease. Either it is on one end, which is just simply tendinopathy, or it is on the other end, which is, a full thickness rotator cuff tear. And somewhere in between, where lies the partial rotator cuff tear, we get a little problematic, or we get, there is little controversy. So let us see how do we go about it. So if I talk about partial thickness rotator cuff tear, it is very simple. So a patient comes with a partial thickness rotator cuff tear. You can, diagnose it with clinical as well as imaging. You diagnose the tear, a partial thickness rotator cuff tear. You put the patient on non-operative modality. And if there is a failure of non-operative modality by 3 months to 6 months, then we take the patient for the repair. Okay, so then the decision is to be whether to debride or repair. We take the 50% rule. And if it is less than 50%, we either go with debridement or we go with repair. If it is more than 50%, we go with repair. Repair can either be a takedown repair. You complete the partial thickness tear and do a formal rotator cuff repair, single row or double row, or you can do a in situ repair. So this slide actually sums up my whole lecture. But if it would have been so simple, the man himself who did the first rotator cuff tear would not have said this. So Codman himself said, I am still in doubt as to how to treat the incomplete ruptures. So what is the problem with these tears? What happens? Why these tears, they create a problem? So number one, there is a lot of variability in etiology. So again, like Dr. Manish said, that most of these rotator cuff tears, they can be degenerative, traumatic. So this partial thickness tear, which is in the middle of the spectrum, so they also have varied etiologies. The bursal side tears can have they have a different etiology. The articular tears have a different etiology. The intertendinous tears, they have a different mechanism. Then their size, the size of the tear, it dictates your treatment. A full thickness tear is a full thickness tear. It may be of any size, you have to repair it down. But size variability in a partial thickness tear, it also dictates the treatment, so making it even more controversial and problematic. Then the location of tear, the articular tears and the bursal tears, they do not behave the same. Okay, so then the second part is, we really don't know the true incidence or the prevalence of these tears. And once we don't know this, we really do not know the natural history of partial thickness tears. Once we do not know the natural history, we really are never sure how to treat a patient. And all of this is happening because we have a limited high quality data, which is comparing, partial rotator cuff tears. Majority of the studies are on full thickness rotator cuff tears. So looking the prevalence of partial thickness rotator cuff tears on cadaveric studies, it is 13 to 32%. But what was, striking was that these cadaveric studies also showed that partial thickness rotator cuff tears have almost, double the incidence as compared to a full thickness tear. Then these studies may be a little skewed because cadaveric studies were usually done on, older cadavers. Then there was MRI based or imaging studies, which shows age dependent distribution. Less than 40 years of age, less than 40 years of age, only 4% of these have tears. More than 60, 26%, and more than 70, 80% of these can have these tears. So why this happens is, just a minute. So there is a discrepancy between cadaveric based studies, and there is a discrepancy between clinical studies. So cadaveric based studies, the most common type of partial thickness tear is an intertendinous tear, whereas when we clinically see, the most common type of tear is a partial articular tear, because the intertendinous tear we cannot pick up on an arthroscopy. But this is the main reason why we don't have a true incidence or a prevalence of these partial tears. So these tears usually these partial do these tears actually heal spontaneously? So there is enough evidence, histochemical analysis, there is clinical evidence, and there is biomechanical studies which have shown that these tears, they do not heal spontaneously, or sometimes, very rarely, they may get a little smaller or they may heal, but majority of the times they do not heal spontaneously. So Fukuda et al. In 1994, they did a histochemical analysis of 35 specimens. There was no active repair at the site of injury. Yamnaka, which was also quoted by Dr. Manish. So there was almost 80% progression to a full thickness tear. They evaluated 40 patients with partial tears, and out of those 80%, they progressed. 10%, get a little smaller, and 10% they revealed to be healed. And there was a biomechanical study also which was done, and which showed there is increased strain on the remaining tissue, which has a propensity to progress. So these tears, in majority, they do not heal spontaneously. So if they do not heal spontaneously, so is there a role of non-operative treatment, or non-operative treatment is just a waste of time? So there is a very good study which was done by Ian Lowe in 2018. They studied 76 patients, 48 males, 28 females, with an average age of 52 years. And all the patients who had a concomitant shoulder lesion, they were excluded. So what they got was that non-operative was successful in 49% of the cases, and 51% underwent surgery. The endpoint of this study was that they actually put all the patients on non-operative treatment. Non-operative treatment ranged from physiotherapy, anti-inflammatories, a steroid injection, and all that stuff. So those patients, those were happy, they were put into non-operative group, and those patients who were unhappy or they had persistent symptoms or increase in symptoms, they opted for surgery, and those who underwent surgery, they were taken out of that group. So this study, they did a clinical follow-up, which was a blinded clinical follow-up, which was done at around 4 years. And at 4 years, after a blinded follow-up, they saw that a mean shoulder elbow score was 85 plus minus 16 for these patients. And overall subjective patient satisfaction scale was 7.5 plus minus 2.3%. How do we translate this into our clinical practice? So this slide tells me that, you know, a patient who has been treated non-operatively, irrespective of not healing the tear, they still maintain their function at 4 years after they have been successfully treated non-operatively. So then they also did an imaging follow-up, which was again blinded, and it was done by two radiologists. So they saw that the tear progressed in 24% of the cases. There was no significant damage in no significant change in 65% of the patients, and actually the tear improved in 11%. So the tear improved does not mean that it healed. The tear improvement was if there is a change in size more than 20% of the actual size, that was considered significant. So if it is decreased, it is improved. If it is increased more than 20%, it has progressed. And no significant change means that the change was in between 20%. So if we see imaging also, out of the 24% which progressed, 8% only progressed to a full thickness rotator cuff tear. And majority of these, which is 76%, they did not progress at all. So non-operative treatment may not be that bad in these patients. So it is I think, fair enough to say that you should first trial these patients for a non-operative treatment. Then they also looked at the MRI studies and see if the tear was quantified as less than 50% of the tendon involvement. So the only 14% of these progressed. And if the tear is more than 50%, 55% of these progressed. So these studies, this study was again further followed by, you know, Amrudi et al. In 2019, they tried to predict that what are the factors which are going to fail a conservative treatment. So they did a retrospective study on 272 patients, and what they found out was that a bursal type of a tear in the dominant extremity, and which involved a tear which is more than 50% of the tendon depth. These are possibly the factors which are going to take your patient into a failure. So these patients, if you see these patients, you have to be very careful that conservative treatment may not work. And if these patients progress, you can go for, you know, a surgery early on. Then there was a clinical study which was done by Kim in 2019, and they studied that when we should repair a partial thickness rotator cuff tear. So it was a comparison. It was a randomized controlled trial, and it was a comparison study in which they analyzed 78 patients, in which group 1, they did an immediate cuff repair on partial cuff tears. And in group 2, they did a delayed repair after 6 months of non-operative treatment. And it was surprising to see, you know, that at the end of the study, both were doing same with no significant difference between functional scores and VAS scores. But in the initial period, at 6 months time, the subset of the patients who underwent a delayed repair, they actually fared well on VAS scores. They have lower pain VAS scores, and they have a higher shoulder elbow score at 6 months. So they concluded that a trial period of pre-operative non-surgical care is reasonable, and immediate surgical repair may not be crucial for the treatment of partial cuff tears. So non-operative treatment has a role. And I think, to conclude about the non-operative treatment, nearly 50% benefit from non-operative treatment, atraumatic tear, non-dominant extremity, and tear involvement less than 50% you will probably see your patient through with a non-operative treatment. This comes with a rider that these patients, you know, 26% of them may progress. So you have to be very careful that you need to, you know, continuously monitor these patients. You need to call them up, which is a little difficult in our scenario, but you should at least be aware that these patients need to be called up for a longer period of follow-up. And if, you know, the symptoms come, they may need imaging to see whether the tear is progressing or not. So the second question is, once you have through with your non-operative treatment and we have labeled it as a failure of non-operative treatment, the patient did not improve or the patient worsened, then the second question comes. So we have to take him or her to OR, And then the second question comes whether we want to just debride these lesions or we want to repair these lesions. So this is a slide which is showing you, two kinds of tear, articular surface tears and the bursal surface tears, and they are graded into grade 1, grade 2, and grade 3. So grade 1 is 3 mm, grade 2 is 3 to 6 mm, and grade 3 is more than 6 mm. So grade 3 roughly corresponds to more than 50% of tendon involvement. So we have the 50% rule to decide that if the tear is less than 50%, so they are better off, they are usually recommended for debridement. And if the tear is more than 50%, they are usually taken with a debridement and a repair. But this may not be true for a bursal surface tear as well as articular surface tear, although they both look the same, but they are actually, their behavior is totally different. So how do we explain their behavior to be different? So there was a very good study done by Nimura, who studied the anatomy of the rotator cuff, and they said that the rotator cuff is not just a tendinous layer, it is actually a confluence of 5 layers. So there is a tendon layer, then there are multiple layers, and then there is the capsular layer. And these 5 layers, these 5 layers are different on the this 5 layer makes a difference on the bursal side and make it different on the articular side. So this picture, which is showing C1 and R1, this is actually, again, they worked, Yagamuchi and Sugaya, they worked on this. And what we were actually thinking, that a majority of the greater tuberosity, anterior greater tuberosity, is full of supraspinatus tendon impression. If you see the R1 is the supraspinatus tendon insertion. It just forms a small part of it. And C1 is actually the capsular insertion. So the footprint just posterior to the biceps is formed by C1 and R1, where C1 is the capsular insertion and R1 is the tendinous insertion. And it will be surprising to know that if you look at this C1 almost is equal to 6 mm to 7 mm. So if you go back and think about your classification of the tear was classified into more than 6 mm is a significant tear. So the first 6 mm of the tear is actually just tearing the capsule on the articular surface, but it may not be the same on the bursal side. The bursal side, so this is on your screen, is the articular side partial cuffness, partial tear. So if you see the articular side tear, first the capsule goes, and then as the tear progresses, then the tendon starts getting involved. Something similar to the clinical picture shown here. And on the other side, on the bursal side, it is the majority of it is a tendon involvement. So these two, although may look same, but they behave totally different. And that is why, the results of isolated Krodaski. So Krodaski et al., they looked at the results of isolated subacromial decompression for grade 1 and grade 2 tears, and they noted higher failure rate on the bursal side tears versus articular side tears. So on the bursal side tears, the failure rate was 29% versus an articular side tear where the failure rate was as low as 3%. And overall, the failure rate was only 8%. So if you are considering a bursal side partial tear, I think it would be wiser to consider a more aggressive approach for the bursal side. So personally, on a level 5 opinion, in my scenario, if I have a grade 1 and grade 2 tear on the articular side, I would go with the standard 50% rule. But on the bursal side, if it is grade 1, yes, debridement and acromioplasty. If it is grade 2 or grade 3, both of them, they go for a takedown and a repair. I don't put the grade 2 into less than 50% rule. So once you have decided that we are going to repair these patients, now the next controversy sets in, that whether you want to take down the tendon and complete the partial cuff and then do a formal repair, a single row, double row, or whatever, or you just want to do an in situ repair, which is more popularly known as a pasta repair. So why consider an in situ repair when we are well versed with the full thickness rotator cuff tear? We do it in and out. So why we need to do a technically challenging procedures? So some theoretical advantages are that in situ repair, it preserves the bursal layer. It do not create a full thickness defect. So biomechanically, it is stronger, it is less gaping, and it is giving more strength, and we can mobilize these patients more aggressively. But the downside to this is that these are technically demanding, and studies have shown that it may actually give worse early results and more stiffness as compared to a takedown and repair. So head to head, this was a study which was done by Snyder Group, and they checked 54 pasta lesions. Mean age was 56 years. They reported 98% satisfied with a constant score of 91 and UCLA score of 33. But when they looked at more carefully, they found that 41% of the patients, they have mild residual pain. And then they predicted that older patients and with significant retraction and absence of trauma, these are the patients which may be having more painful, which may have a residual pain, and they may not be a good candidate for these kind of in situ repairs. So they recommended that young patients who are less than 50 years of age, who have only a partial articular tear with a healthy non-degenerative bursal layer, these are the patients who may predictably do well with a pasta repair or an in situ repair. Head-to-head studies, they have shown no clinical superiority over each other. But if you look at different studies, these are all randomized studies, level 2 randomized studies. They have studied whether a takedown is better or a transtendinous or an in situ repair is better. So if you see the scoring system does not have a significant change in both the groups. So all these have no significant change in scoring system. But if you look at a little in the subgroup analysis, so Castana, they show that there was a better strength improvement in their subset of patients. And Shin also showed that they have better early results in terms of pain relief and shoulder elbow scores and range of motion scores. And you will be surprised that both of these, they were more in takedown patients, in which the cuff was taken down completely and repaired. At the end of 1 year, there was no difference. So no clinical superiority of any technique over the other, as shown by Rossi et al. In 2020. So this is just a small case study. So this is a young patient, 45-year-old male, who had a history of trauma, and he first underwent a non-operative treatment, trial of non-operative treatment with worsening of symptoms. No injection was given to him. The pain was severe to the extent that he had a kind of a pseudo frozen shoulder kind of a picture. Because of the pain, he could not move. Under anesthesia, the range of motions were full, and he had a partial articular rotator cuff tear. So clinical picture, he had a partial articular rotator cuff tear, which was debrided. After debrided, you can see, the underlying layers, and these layers are retracted. So on the bursal side, it was checked. Bursal side was absolutely okay. There was no bursal tear. Bursal layer was good, healthy. And if you see the spinal needle marking, the spinal needle also shows it is not just coming out. So there was a significant layer. So I did a transtendinous repair in this particular patient, and he did well. So just to conclude my talk, these patients are patients with partial thickness rotator cuff tear. You take them into a non-operative modality. They fail. You assess the tear, and then 50% rule it hold true. If it is less than 50%, you debride, and along with plus minus and acromioplasty. But if it is a bursal side tear, just be aware that the bursal side failures are more. And if it is more than 50%, you can either take down and do a formal rotator cuff repair, or you can do an in situ repair. Both have shown no clinical superiority over each other. And what is best in your hand, you can do that. So I still feel I'm still in doubt as to how to treat these incomplete ruptures. Hope I have tried to make it somewhat more clearer. Thank you.
Thank you, Dr. Nitin. This was extensive because this is a gray zone in this partial cuff tear. Mostly, probably the bursal cuff tears are more painful, That's why the patient
Yes,
agrees
absolutely.
for the operation. And the articular side, there is, though it is more on the MRI, the patient don't agree for the operation. Only because of the pain, the patient agree for this thing. So it was a great talk. I think we have covered mostly
Excellent, sir. I think he has really concluded things in an excellent manner.
Excellent.
And a very good presentation on a very, very difficult topic. And just spellbound, sir, I would say.
Yeah. I was thinking that it is a big talk that we have coincided is nicely. Thank you, Nitin.
An excellent talk.
Thank you, sir, for your comments.
Comments
Well,
from
the
Dr.
big
IPS
problem here is that is the articular surface tears. So Bansal, we are always very aggressive, so we don't have any issues. We usually take it down and do it. The problem happens in articular surface tears, and as you said, it's more of a capsular tear. So I think it is very difficult to even apply that 50-50 rule on the articular surface.
Absolutely.
So that is why there the issue comes, whether we just debride it or do a trans-tendon repair like you did it, like a parachute technique. So how did you, in your case, decided that, I mean, as I saw in the picture, and I might be wrong, that you debrided the capsular area which was torn, and you still had tendon which was apparently looking good, but you then opted for a trans-tendon parachute kind of repair. So were you, was the patient active? Was he having a dominant limb and you were skeptical that this may fail in future, or what was the reason you actually went ahead and did? Because a lot of these trans-tendon repairs tend to become more painful after surgery.
Absolutely, sir. They tend to become more painful. So this was, I will not lie to you. Till the end of my procedure, I was in a fix that whether to take it down completely and repair it, leave it. But he had a good tendon. There was not much of a kind of a frozen element. So then I decided to give it a chance because it was traumatic. He was relatively younger individual, active individual. Had he been 10 years the other way around or atraumatic, I would have taken it down and completed the tear. So the tendon was actually very good. And the bursal side, if you see, I did not do any bursectomy before I presented that picture of spinal needle going through. So the subacromial side was also pretty okay. And this patient I operated earlier, almost 1.5 to 2 months down the line.
The footprint was not exposed. In this case, we couldn't see the exposed footprint on the supraspinatus, which means probably it was more of a capsular tear rather than a fiber tear.
Absolutely.
So when you do a trans-tendon in such cases, would you actually end up slightly medializing the insertion? Because a footprint is not exposed. Honestly,
absolutely, sir. You cannot medialize the repair.
Yeah.
If we medialize the repair, I think that is also one of a negative predictor for an outcome.
Yes.
So what actually has to be done is actually, Siddharth knows I had a crash of my laptop, so I do not have the videos and everything. But, I always tend to put a suture medially and bring it laterally, actually. So you cannot medialize your repair. You cannot just press it. This was just a rough picture which you saw in the end. This is actually not the proper picture, which it was just for the purpose. So it is giving actually a wrong impression.
I think I'll ask two things. How much thickness was the tear? What do you think? What was your estimate? 50%, 40%? What was your estimate?
So that there was no estimate as such. The cuff on the bursal side was good. It was a healthy cuff on the bursal side. Sorry.
So why did you opt for repair and not just leave it after debridement? I
think that was my question actually.
You can actually, Siddharth, you can actually leave it. You can actually leave it. That is why it is a controversial topic.
That is the question what sir is asking.
Siddharth, age of the patient is also very important. If it is a young guy, if you see
that is what I was asking. Was it a dominant limb?
He's a young guy.
Was it an athletic guy that you were skeptical that it
he was not an athletic guy. He was a young guy with a dominant limb involvement, and he was a kind of heavy kind of a worker. Like he has to do a lot of labor work and all those stuff. So
yes,
this is probably the reason I choose to.
Dr. Pandher is waiting. Nitin, just for a question to you.
Can I just add a point? Actually, what I do in my practice is if I have a partial tear like this, it is the spinal needle that gives you some clue when he is passing that needle.
Absolutely,
so if I pass
absolutely,
a needle
Dr. Pandher.
A partial tear, generally if the rest of the cuff is reasonably good, you have that feel of the needle that it will go through a tough tissue and you'll feel it is going through a good healthy cuff, and you generally don't repair those. Sometimes when you put your needle, it will simply slip through that part of the partial tear. And if the needle goes very smoothly through that partial tear, then actually you are looking at a tear that is, even though it's not looking like a significant thickness tear, but it has an interstitial component to it, the interstitial tears that we discussed. And in that kind of situation where you actually find that the quality of the tendon is not so good, it is always good to repair, because I personally believe so that patient is going through almost everything. Absolutely. The surgery, the rehab.
But in that case, you don't do in situ repair because you are not happy with the tendon quality. Yeah. Then it is better to take down and do a
take down.
Just a small question. The Barkart always told us that intersubstance and sometimes the quality of the tissue, you have to do the bubble test. Have you anybody done this bubble test in your lifetime? I have never done that.
Yeah, it's usually for the bursal surface we do it.
Bursal tear only.
In the bursal tear.
You do that
once or twice, though it doesn't make any much difference to the clinical decision.
Nitin, have you ever done this bubble one?
Yeah, done.
No, sir. I have not done a bubble test. And but if you just give me a minute, I'll just summarize what I do actually. So what I do is what Dr. Pandher is saying. What I do is, on the bursal side, I am very aggressive. I think it is not a matter of controversy. So we always take them down and do it. On the articular side, this particular tear, it could have been left after debridement as such. Then there is always, you are in a double mind sometimes whether to do some kind of a repair or not. If I take the spinal needle and it just goes through like it is just going through the cheese. So I know that there is not a good quality of cuff there. I will not attempt an in situ repair. I'll complete the tear and do a formal rotator cuff repair. In this case, it was good. You can actually feel it is going through a wall kind of a thing. So yes, I could have left it like that, but somehow I choose to repair an in situ. So the thing is loud and clear. This can be a little bit of, opinions can vary intraoperatively and all that stuff. But usually
that is why we have a controversy here, sir.
That is the aim of this discussion, Nitin, that we need to take out the conclusions why and how we do it.
For me, in situ repairs always take a back seat. Always take a back seat. I am more in favor of takedowns and repairs. But somehow I did it in this case, and I showed it. Although the patient is doing well, and
perfect.
Okay, Siddharth. Thank you. The next one, Siddharth. Otherwise, will be the time management will be a problem.
One quick line, and we can proceed.
Nitin, I just had one quick question, and this is for everyone. Then we'll go to the next topic. Sorry. If you've got a dorsal-sided tear, do you routinely do an acromioplasty, irrespective of how bad the acromion is? If you conform it to the extrinsic theory,
Manit, I don't do a routine acromioplasty. Only if it is a significant type 2 acromion or a type 3, yes, I will definitely do. But in a good looking acromion, I am not going to, touch the acromion. There is no need to do that. There is no need.
Okay. I think we are good to go, and let's proceed.
Thank you so much.
Thank you very much.
Okay. Going further, sir, I'll invite Dr. Pandher, Dr. Dilbans Pandher from Jalandhar. He's doing extensive work in scopy and plasty also. Sir, your take will be to open or to do arthroscopic. It's our biggest dilemma with the orthopedic surgeon, which way one should go. So please proceed with the talk, sir. Open versus arthroscopic repair.
Thank you, Siddharth, for the invite and for this discussion. And when I got this topic, actually, I am an arthroscopy surgeon, and I was more convinced that why mini open. So I looked to the literature, and in my talk, I'll just take you through how the events unrolled in the history of rotator cuff repair. And you'll agree with me in the end that arthroscopic is the answer. So if we look back, the rotator cuff repair came into existence in somewhere around mid 1950s, and the first article was published in 1951. And till then, there was a gradual increase in articles published, and 2019 we had the maximum number of articles published. Then people started doing arthroscopy, and after the knee, shoulder joint was the next accessible joint for the arthroscopic repairs. And if we look at the published literature, in 2003 we had only 36 publications, which increased to like 295 in 2019. But the publication, if you see, the first publication was in 1988. Next, if we look at the publications for mini open rotator cuff, it actually started in 1993. So it was almost 5 years after the first arthroscopic rotator cuff repair publication that people started looking at the mini open rotator cuff repair. Why so? It was actually that after the open repair, people wanted to do arthroscopic rotator cuff repairs, and the procedures where it was technically not possible were converted to mini open. So mini open is a child of arthroscopic rotator cuff repair. This first article published by Kim in 2003 in Arthroscopy Journal is exactly a very descriptive about the state of affairs, that all arthroscopic technique or a mini open salvage technique where arthroscopic repair was unsuccessful. And they found that the result in salvage procedures where arthroscopic repair was unsuccessful and they converted into mini open were also as good as the arthroscopic repair. Another article again in Arthroscopic Journal, the long-term retrospective outcomes. So here again, they were doing arthroscopic assessment and subacromial decompressions before converting to the mini open. They found something good, that in arthroscopic group, there was no arthrofibrosis, but whereas in mini open group, 4 out of 29 patients had arthrofibrosis, and greater motion in the arthroscopy group was noticed at 6 and 12 weeks. So as we progress in the timeline, in 2005, we have a comparison of again arthroscopic and arthroscopically assisted mini open. All the studies, they were finding like equivalent results and equivalent patient satisfaction. Another study, again, they did like 10 or 9 arthroscopic rotator cuff repairs. Then they matched the cohorts with 12 mini open repairs and compared the outcomes. Again, the results were similar. So what we are saying is that actually people are trying to do arthroscopic repairs, but somewhere where it is not possible, they are doing mini open, and then they are comparing the results. And the outcome is that, okay, mini open repair is as good as arthroscopic repair. Another article in 2006 about all arthroscopic versus mini open rotator cuff repair, again a retrospective study. The difference here is that they were evaluating the defects with ultrasound at follow-up, and all arthroscopic repair, the re-tear rate was 24%, and in mini opens it was 27%, though it's not statistically significant. What was interesting was that original tear size larger than 3 centimeter was 7 times more likely to have a re-tear. And again, their study again reported that there was no difference in regards to pain or outcome scores as far as the 2 techniques are concerned. We further progress in time. By this time, people started doing the arthroscopic versus mini open cuff repair in a prospective way. And they were doing arthroscopy in both the cases. The acromioplasty and biceps pathology was addressed arthroscopically, and then they compared the results that the mini open technique is giving them good results. So similarly, a randomized clinical trial comparing open to arthroscopic acromioplasty. So this study is actually that they are doing open repair, but in half the cases they were doing arthroscopic acromioplasty, and in the rest half they were doing the open acromioplasty as well as the repair. At 3 months, they showed that open repair had statistically significant better outcomes as far as the range of motion and other things were concerned. In 2012, we further progressed in the evolution of arthroscopic techniques, and now we have a randomized arthroscopic trials where arthroscopic repair and mini open repairs were done in a prospective study, and the significantly lower pain scores were observed on day 1 and day 2 in the arthroscopic group. So the good thing that was coming out was that you have less pain immediate post-op, you require less analgesics, but the difference was not there at 6 months. So arthroscopic and mini open repair had equivalent clinical outcomes. So this is what is actually happening. And as we progress, there are more studies. There is a slight difference of re-tear rate, where like in this study, the arthroscopic group had 70% and the mini open had 13%. Adhesive capsulitis was more common in mini open group. But all these things, they are not statistically significant. So every study is concluding that arthroscopic repair is as good as mini open repair. So another article in Clinicals of Orthopedic related research that no difference in postoperative pain in arthroscopic versus open repair, the difference of questionable clinical relevance or a borderline statistical significance favoring arthroscopic intervention in the second post-op. So some studies are reporting that first 2 days the pain is less. Another study is reporting that in the second week the pain was significantly less, but actually it does not transmit into any kind of better results in the long term. And similarly, we have another study that arthroscopic versus mini open rotator cuff repair, a randomized prospective. This study is important because they did a magnetic resonance arthrography, or the MRI arthrography, at 24 months follow-up. And what is interesting about this study is that full thickness tear in the arthroscopic rotator cuff repair displayed better shoulder strength and a significantly higher re-tear rate. So we had higher re-tear rate in the arthroscopic group in this study, but still they displayed a better shoulder strength in compared to the mini open cuff. So can we give the benefit of doubt to the deltoid, that because in arthroscopic group you are not detaching the origin of deltoid to do the acromioplasty, because if you are doing a mini open acromioplasty, you have to raise at least 1 to 2 centimeters of the deltoid from the anterior lateral angle of the acromion to do a proper acromioplasty if you want to do an open acromioplasty. So another study, satisfaction, function, and repair integrity after arthroscopic repair. This study actually favored the mini open repair, that the mini open repair gives you better healing. And it might, because if you ask me, like when you do a mini open repair and you repair the tendon into the bone tunnel, that you create a groove in the greater tuberosity and pull the threads out, you give a significantly better base for the tendon to heal. So it is actually sitting into a depression in the bone, and it has much better chances of healing in comparison to the surface contact that we can generate with a single row repair or a double row repair when we are doing the arthroscopic techniques. Similar things were again published in meta-analysis. There are variable meta-analysis. I'll just skip these because it is the same thing. So we have individual studies, and then we started getting the meta-analysis. Everybody is saying that mini open and arthroscopic, there is no difference as far as pain scores, VAS scores, range and motion and everything is concerned. Systematic reviews and the recent study published in 2019, they again compared the effects of mini open and arthroscopic, and pain and range of motion were similar. So the question is, why do we opt for arthroscopic repair if everything is similar? We opt for arthroscopic repair because it gives us better assessment of overall pathology of the shoulder other than the rotator cuff tear. Long head tears, fraying, synovitis can be evaluated and addressed. Arthritic changes can be documented. Associated articular side cuff tears can be addressed. Labral injuries can be addressed, and you can plan your acromioplasty. I'll tell you in detail, like how can you plan your acromioplasty. So these are some of the incidental findings. So this is like fraying of the subscapularis in a small rotator cuff tear. So if you know that there is fraying, you can document it and you can modify your rehab accordingly. This is a large cartilage defect that I found in one patient who was actually posted for mini open repair. And the only reason to do mini open repair at my hands is financial, when patient cannot afford the cost of anchors. And this, the video on your right is showing a partial or type 1 subscapularis tear where upper 1/3 of the subscapularis is torn partially. So this kind of tear you'll not be able to see from outside if you do a mini open repair. And this superior labrum, again, type 2 to type 3 kind of detachment is something that can only be evaluated arthroscopically. And the full thickness cartilage loss, we looked back at the MRI. MRI was just done around 2 months ago. There was no sign of any damage to the cartilage in the MRI. The bone was looking reasonable because this lesion is after the debridement. We found that whole of the cartilage in this region was like flaky. And the first thing that comes to your mind is that, was it a result of intra-articular injection steroid given by somebody? So I asked her specifically that, did you get any kind of injection? And patient said, no injection was given to the shoulder joint. So this is something that you'll miss. You will miss this partial subscapularis tear which is again like for a patient taken up for rotator cuff tear, we found a partial articular surface subscapularis tear, which needs to be addressed. So this is just few slides showing how we repair it. So this tear will not be visible from outside, and most of the times when you're not doing the arthrogram or you're doing a simple MRI or plain MRI, this kind of partial tears, they almost sit back at a normal anatomical attachment, and you might not pick these up on your MRIs. This is another lesion of long head of biceps. You can see the fraying of biceps, though sometimes you can debride and leave them, and this is a full thickness supraspinatus tear. You can see the defect, and this is fraying of subscapularis tendon. So all this needs to be documented so that you can tell your patient, okay, there is additional damage and we have to modify our approach accordingly. This is a subscapularis tear, a full thickness subscapular tear. And when you look around the long head of biceps, you see that there is associated partial articular surface tear of the supraspinatus. So this is a small area, as we were discussing, the cheese quality kind of resistance to the spinal needle. But when you see this kind of tears, you know that you have to address these two. And if you base your repair only on your MRI, you might be missing all these tears. The next is that you can plan your acromioplasty. So on your screen, you can see two. On your left-hand side, this is a lateral acromial spur. You can see the deltoid, the burr is coming from lateral side, and deltoid is attached, and the bony spur is visible just next to the attachment of the deltoid. And on the right side of your screen, you'll see that the bony spur is actually tilted inwards. So from outside, you will not find a very big acromion spur. And this is again something that I believe might be missed in a mini open repair, because you will not find out the spur that is actually pointing inwards, and you might miss it. And if you miss it, the patient will land up in recurrent or high chances of re-tear, because this will impinge upon the repair that you'll be doing. And second thing is that what we have observed is that this medial type of spur of the acromion causes or is more commonly associated with upper third subscapularis tears and long head of biceps injuries. And the spur that is more lateral is generally associated with rotator cuff tear, where it does not actually harm the long head of biceps. So next, the incidence of pathological changes in long head has been documented in various studies. This arthroscopic subacromial decompression study, where they did around 1 or 200 shoulders, and they said macroscopic degeneration in long head in 40% of the cases, or 80 cases. The rotator cuff tear was found in 91% of these, where the long head injuries were associated. The remaining 200 shoulders, 70% had rotator cuff tears and 23% had full thickness. So this is a study again from 2000, where people were doing arthroscopy. They were trying to learn arthroscopic rotator cuff repairs. So they were doing subacromial decompressions and then converting it to mini opens. The incidence of severity of long head of biceps tendon lesions was again published in 2005, and they found that only 29% shoulders were without lesions in the long head of biceps. Others had type 1 in 41%, type 2 in 8%, type 3 in 10%. So there is a significant incidence of long head tendon injuries associated with rotator cuff, which we cannot ignore. Now, again, why are we looking at all these tears? Because I personally believe that literature, what is being published, what is being addressed, or what is the outcome of even meta-analysis is somehow not to be believed 100%. You have to go by what you feel and see in your patients and how you treat it. The structure, because there is this study that was published about the structural integrity of the rotator cuff repair does not correlate with patient function and pain. A meta-analysis, so there is not a clinically important validated function outcome score or pain for the patient who have undergone, regardless of the structural integrity of the repair. So there is no correlation whether the tendon has healed well or not. And the last thing that we always argue about the mini open technique is that it is cheap. So it is definitely cheap in India, because we are providing our surgical services very cheap. And if you talk about corporates, and big centers, there the cost of anchor will be negligible in comparison to the cost of the whole surgical package. And this study from UK, they actually found that the overall treatment cost at 2 years was around 2567 pounds for the arthroscopic surgery and 2699 pounds for the open surgery. So it is no way cheaper if you are doing it in an advanced ward, or where the patient is actually paying for the surgical services and everything, and the cost of anchors is actually negligible if you bring it down to the cost at which the best bargain you can get it. So to conclude, the final results are similar for arthroscopic and mini open. Surgeons have evolved from open to arthroscopic, deviating to the mini open techniques when they were not confident about doing arthroscopic. Surgeons who do not have skill or access to arthroscopy can perform mini open repairs with equally good results. However, arthroscopic repair has its own advantages in terms of evaluation, associated pathologies, and ability to address other lesions. COVID pandemic has taught us one thing, that among many others, that data published in in-test journals of highest impact factor is not always to be believed. So many studies were withdrawn from Cochrane, but when they were initially published that all these drugs are doing wonders in COVID patients, it is best practice to keep your record of everything you do and analyze your own results and see what is actually happening at your hands. Thank you.
Thank you, Dr. Pandher. It was an excellent talk, because I think the juniors, when they start with, they all do with the maxi open, then they come around, they graduate to the mini open, then go ahead with the arthroscopy. We have all been gone through all these 3 phases. So I think mini open is not that it has to be abandoned. Like, I think if you are not been very good at doing the all arthroscopic cuff repair, please don't accept an inferior quality cuff repair just for the sake of the surgeon's ego. You can go ahead with your mini open. Mini open problem is hardly in the initial 3 weeks time. Probably the patient will be having some pain because of the deltoid and all these things. But the end, if you do repair proper way, I think the patient will be grateful, rather than having your own surgeon's ego. I do the 50% job with the all arthroscopic, but never accept your cuff mobilization the best possible way and the best possible repair with your anchors. Am I true?
Yeah, definitely. That's what I am stressing upon, that all the big surgeons in the world of arthroscopy have evolved through these phases.
All 3 phases.
Trying to do
maxi open, mini open, and then all arthroscopy.
Yeah.
Sir, I think it also makes a difference as to, where you are. So if you're at a center that doesn't have a scope, if you're at a center where there's no one that's been trained to do arthroscopy, then it's probably a, wise thing to do a mini open. And, all the literatures, as you said, Dr. Pandher, it shows that arthroscopic is equal to mini open. So I can also apply that same argument and push mini open and say that, hey, look, I'm doing mini open. It's equivalent to arthroscopic, right? One question I really wanted to ask you, Dr. Pandher, was what about the biceps? What do you do for the biceps? Are you a killer, or do you do tenodesis for the biceps? And how do you decide in your cuff repairs what you would like to do?
Actually, it depends upon the quality of the tendon. Like, I am not a very aggressive killer. If I find that the biceps tendon is reasonably good, there is marginal fraying, I can debride it and leave it as such. But if I find that the tendon is like 30-40% damaged, then I'll definitely kill and do tenodesis. But I'll not go in and first cut the biceps and then think about what to do with the cuff.
Another important point is age of the patient. Good. If your biceps is good, you're going to leave it anyway, right? You're not going to.
I think you're the perfect murderer who just kills the bicep as soon as he enters the joint. He's the biggest enemy.
French.
Yes, money.
I started, and I want to share my experience as well, right? So when I started doing a lot of, I used to cut almost all biceps. I used to leave biceps that are good, but any biceps that was bad, I used to cut it, right? Now, one of the things that I found, and then I went back into the literature and I saw this as well, is that about 40 to 50% of patients would come back with that biceps cramping pain. So they would still come back and complain that, look, I've got this pain, it's radiating down my arm, and it usually disappears around about 3 to 4 months post the surgery. But that first 3 to 4 months for them, they do have this bad biceps pain. So I shifted across, to doing more and more tenodesis nowadays. But that's the thing I wanted to ask you, that if your tendon is not good and you've made the decision you want to do something for it, what's your indication for cutting and what's your indication for tenodesing?
But if you ask me, I would have actually cut and left alone at the most 2 or 3 biceps in my whole career. Generally, I do the anchor tenodesis in every case. Like my standard, if I have to cut the biceps, I will put the needle through the biceps tendon when it is attached, pass a suture through it, leave it aside, and I'll put my first anchor at the base of the biceps. I'll wrap the thread 2 or 3 times around it and tie it down over there, and I'll use the same thread to hold the anterior part of the supraspinatus, just to give it because you cannot put too many anchors in that narrow space. Just to utilize one anchor and get a bite over there, because the next anchor will hold, get a good purchase around at least 1 centimeter posterior to it. And if you ask me what is my experience, all the biceps that I have cut, like, patients were fantastic. They said, oh, like, my shoulder is fantastic the next day, and they were happy. But they were again coming to me with the blue discoloration and the Popeye and everything, and they were asking me, okay, what is this? So it is that.
I wonder, do you use size as well? So this is something I wanted to ask everyone. So do you use the size of the arm as well as a sort of a indication of whether to cut or tenodese? So if you've got a fat lady, she's really not going to Popeye, right? Whereas if you've got a nice, thin, 60-year-old male who is going to Popeye, so does that really influence
For me, it is just like, if the patient is like, people put it at 60, I put it at 70, 75. If the person is around 70, 75, I have cut few, but they were fantastic. But still, that Popeye thing, that looks so ugly, and I just don't like the ugly thing. So I better believe that it's just like 2 bites more, and you fix it over there. And believe me, like, I have not experienced anybody coming back to me complaining of any pain or any symptoms related to the tenodesis that I have done.
Okay, I think because of the paucity of time, let's stick to the present topic, and with the mini open and the arthroscopic. Dr. Ravi Gupta, sir, are you there?
I think he joined. He is some network issue is there. 2 or 3 times sir has joined.
Sir
network issue is there.
Yes, sir, your comments. I would like to conclude this talk with your comments, and then we can switch to the next one.
I think Dr. Pandher has done a real justice to the topic.
Yes, sir.
And I am of the same ideology. In government setup, cost is a concern many a times. So I can use intraosseous sutures for doing this mini open. But the people who can afford, I definitely prefer whole arthroscopic. It has its own advantages. And sometimes when I am cautious about the osteoporosis in 2 elderly patients, I always prefer mini open.
Sir, what about massive tears? Any advantage you have felt for a mini open in massive tears, or do you feel it's the similar type of picture with both the?
See, the advantage of whole arthroscopic is you can anytime convert it into mini open if you think that you need some more help. But I think the size of the tear is not a problem. If you mobilize it really well arthroscopically, you are able to pull it back.
And what does osteoporosis have to do with your choice of surgery?
Can you repeat?
What does osteoporosis have to do with your choice of surgery?
The pull of the anchors, the pull out of strength of the anchors in osteoporotic bone is they come through, they get avulsed in post-operative period. I think all of you might have seen in your cases, the anchor is lying in the subacromial space, but the intraosseous sutures, they don't. Because the bite of the bone is too big, too broad.
If I had an osteoporotic patient, I wouldn't change my surgery to do a mini open surgery just because the patient is osteoporotic. I would just use a better quality anchor.
Manit,
That's why you are different.
Manit, I think sir has a valid point that in osteoporotic, taking a bite of anchor versus putting an intraosseous suture, that is the thing that what he's hinting at.
But
And
that's fine.
that takes a
Everyone
valid
has,
choice.
Siddharth,
Yes, sir.
everyone has individual experiences,
Yes,
and you keep on gaining experiences as you grow old. So
Yes, sir.
let everyone learn, isn't it?
I think, sir, let's shift to the next talk. And
Siddharth, just one thing.
yes, sir, please.
Like Manit, I have recently converted my first and only case till date to open for this only reason that Dr. Ravi has pointed out that we had like 5 mm metal anchors, and I love the 5 mm metal anchors because they generally don't give up. They'll catch hold of somewhere. But it was like so soft that when you put in the anchor into the defrosty thing, it was like wobbling around. Like generally, if you do the tuck test, it generally holds. I sometimes believe that the tendon flips under the subcortical bone and it still holds on. And if it holds on, you repair it. It was a very small tear for single anchor, but the anchor was like so loose that I thought it's better to take it out right now than to take it out
Sometimes
tomorrow.
the bone is like butter. Sometimes.
Yeah.
Yes.
So irrespective of the type of anchor, and the incidence is only say 1 in 50 or 1 in 60 where you get such kind of bone. So you will only see it when you do 100 cases or 200 cases of repair.
Yes, Dr. Manit, you see the Ravi Gupta sir and me, how much he has lost hairs and what is the condition of my hair. So this is the experience you have to take what Ravi is telling. Okay, so we can go ahead to the next one.
Yeah, the next one is biggest problem we all face in the practical scenario. We do a repair, we are very happy or we are skeptical, and the patient suddenly is off. You don't find the patient 6 months or 1 year down the line, he walks into your OPD. Sir, मैं बहुत अच्छा चल रहा हूँ. Yes, sir, I am in real agony. I have done a mistake. So we'll have Mukul, the youngster, the youngest of the lot in our Tri-City, to address this issue of patients who have had a repair, massive repairs, and then lost to follow-up, then presented after some time. Let's see what Mukul has to say about it. Mukul, over to you.
Thank you, sir. It's an honor and a privilege for me to be standing here among my teachers and my seniors. And I'll be sharing a case which I did about a couple of years back. So it's a neglected rehab after a massive cuff repair. So I have nothing to disclose as such. So to define massive, Cofield described it as a tendon tear which is more than 5 centimeters in its greatest dimension. Any tendon tear which involves 2 or more tendon. Burkhardt said classifying it as a pattern of a crescent shape, U-shaped, L-shaped, or a reverse L-shaped, and on an MRI grading of the amount of retraction, a grade 2 or a grade 3 pattern retraction, which is almost crossing the mid of the humeral head or across the glenoid as a massive tear. But we all know that whenever we offer a cuff repair to the patient, our goals are that we improve his pain, we improve his strength, we regain his movements, and in essence, we restore the function. So I'm going to put forward this case from which I had learned. This was a 55-year-old male. He was a shop owner. He had a fall and he used his arm to break that fall in May 2018. And he complained. He told that he had a functional shoulder prior to that. So his clinical complaints were mainly left shoulder pain, night pain, and difficulty in overhead activities. His X-rays were unremarkable. There was no bony injury. He had taken a fair amount of conservative trial, but had not much significant relief in pain. So actually the problem with youngsters starting out as arthroscopic surgeons are that initially we are all traveling surgeons. So shadow surgeries are like part and parcel of our initial arthroscopic days. So one of my colleagues, this patient consulted him and he called me up and told me these are the findings, that the patient's cuff clinical examination is weak. He had a weak elevation, but his passive movements were preserved. And he mails me these MRI pictures. These coronal scans going from front to back appears to be that the subscap is relatively intact, a lot of synovitis and bursitis. As we go more posterior, tracing the biceps and anything behind the biceps. So I can see that, yeah, there is something there, almost the tendon is torn and lying there at a grade 2 retraction. The tendon quality also seems to be not that good, reassuring. And as I go back, even the infraspinatus has also come off its insertion. And looking at the axial cuts, the subscap appears fine anteriorly, but posteriorly the infraspinatus is torn. And looking at the sagittal views of the insertion of the cuff, in front of the biceps, it looks that the subscap is relatively intact, but behind the biceps, the posterior cuff is off. For me, the most important cut is the T1 sag, which lets me decide whether this patient will have a good function after a cuff repair or not. So looking at the T1 sag, I thought that, yeah, the muscle bulk is relatively quite preserved. He should have a good function also even after repair. So I went in. This was the initial arthroscopic picture. Sorry for the bad images. Almost a relatively immobile cuff. So I did a capsular and a bursal side releases. I didn't do an interval slide. Still, I had a lot of trouble. I had to pull a lot to bring it. It was under tension while trying to bring it over the footprint. So I finally decided to do a partial cuff repair. I just medialized my anchor placement, put in 2 double-loaded anchors in a Masson Allen type configuration, and this is what I could end up achieving on table. I thought that I had done a reasonable job, and these were the post-operative X-rays, the medialized cuff repair. And I thought that I'll protect him as it's a massive cuff tear for the initial 6 to 8 weeks, then start him on a scapular-based exercise program, gradually increase his range of motion and start strengthening after 3 to 4 months. But as doing it in another colleague setup, you generally don't know what the follow-up is. And when I called up my colleague to know how is the patient doing, he told me that the patient hasn't reported back ever since we did the cuff repair. So it's almost now 2 years down the line. I told him to give me that patient's number. I called him up, and the patient, he was a shop owner. He's comfortable relatively. He has minimal pain on overhead activities. He has no night pains, and he's able to do his activities of daily living. But this is his 2-year function. He has a weak elevation, relatively weak external rotation, but he is able to take his hand behind his shoulder, and that's his internal rotation. So for me as a youngster, the lessons which I learned are that massive cuff is a challenge to treat, but it's even more challenging to get good results. Cuff repair is half the job done. The pending half is rehab compliance of the patient and assessing and addressing any deficits on the follow-up, which we are not able to do if we are doing shadow surgeries. And proper discussion and counseling with the patient that what to expect post-surgery, the timeline of recovery, and stressing the need for follow-up. That is very important. With this case, I thought that, yeah, massive cuff pain relief is still relatively predictable in massive cuff, but the function and strength gains are guarded. Our patients are relatively quite forgiving in a way, because if they get a pain relief, they rate the surgery as good, but probably that strength, even if that strength gain is not there, they still forgive the surgeon. And it is, I think, very important that the force couples are balanced with a good rehab program once the cuff heals or is starting to heal to optimize the outcomes. Probably everybody is talking about the type of anchor, the surgical technique. Probably we as arthroscopic surgeons are striving to master that thing, but I think the rehab is also an important part altogether. Thank you.
Thank you, Mukul, for touching a relatively untouching zone of shoulder arthroscopy and repairs. And I think you are echoing the words of Dr. Ashish Babulkar. I think he's a teacher. And you're really echoing his word, focusing on the rehab thing. He's one of those rehab guys who has a very strong focus. And that really makes a lot of difference. Because at the end, what matters is the result. So comments from the seniors and questions, please.
Yes, the problem is that if you just do the cuff repair and the physio is not supervised, I assure you you will have a very, very poor result of your cuff tear. Because if the post-cuff repair, this guy becomes stiff, then it's a nightmare for the surgeon, nightmare for the patient, and it is very hard to come back, and they are more painful, and they will take off every week. They will come to your chamber and they will just bug you just.
Yes,
Dr. Pandher, your opinion, Dr. Pandher.
Sir, actually, I would just like to tell Mukul something about the MRI images that he has shown. That looking at those MRI images, the muscle wasting was grade 3. So looking at those MRI films, I would anticipate a cuff repair, and it was not kind of easy thing that you should not be surprised to find a cuff that's not coming back, because if you look at the muscle wasting and everything, it's very gross. And the good thing was that you were still able to pull it back, because there is not much fatty infiltration in the muscle. If you look at the muscle, there is lots of fat around the muscle, but the amount of muscle that you are left with is not showing too much of fatty infiltration.
Point taken, sir.
So I think we can move for the next topic.
Yeah.
Cuff and a lot of cuff movement. Let's talk about stiffness, the polar opposite, and I think the most common anticipated problem more than the actual problem. Everybody feels every shoulder problem is a frozen shoulder or a stiff shoulder. So one of the most difficult scenario I've discussed in any of the conferences or discussed with anybody is when you have a rotator cuff tear which is significant and you have a stiff shoulder, frozen shoulder. But the answer I've got with seniors or colleagues have always been, don't touch it. It's a dangerous thing. Let's see what Dr. Inderdeep has to say, and let's see if we can reach on a consensus to what to do with such a difficult situation.
Yes, Siddharth, from the fast slide, it said we can appreciate. It will be interesting talk.
Yes, sir. It's Inder from Punjab, and Punjab is famous. 8 p.m. se ke baad to वैसे हम कुछ नहीं करते.
It has to be interesting from the very first go.
हाँ सर, ये पहली स्लाइड होनी चाहिए थी हमारी. चलो. Inder, go ahead, please.
Good evening, everyone. So this slide was intentionally put up because I never knew RC meant something else apart from this. RC, so when I joined orthopedics, then we came. I hope I'm audible.
Yeah, Inder, you're well audible, well visible. Please go ahead.
Perfect. So RC for me it was this, and frozen for me it was just ice. So the topic of the day is rotator cuff tear with frozen shoulders, which is a big controversial topic. And so let's look into it. So if we look at the prevalence of concomitant cuff tears with adhesive capsulitis, it is around 12.3 to 41%. So now there are two problems. There is a cuff tear and there is a stiff shoulder. So we have to look into it and manage these two problems accordingly. So what happens in all this adhesive capsulitis or frozen shoulder or stiff shoulder? We need to look into it. What's happening in the shoulder? So there the structures are tightened up. The joint volume decreases to almost 5 to 10 ml, which is normally around 35 ml. The pathogenesis can be idiopathic, secondary, or a tertiary cause. The thing we are looking today, it has an intrinsic cause, which is related to rotator cuff, which is torn. And how does patient present to us? They will have a gradual onset of symptoms and they will complain more of stiffness. For females, it will be more like difficulty in doing their undergarments. For males, it will be inability to reach the back pocket to take out a wallet. And they often complain of night pain. And we should always ask them about the comorbidities, which is very important, such as diabetes, thyroid disorder, and cardiac disorder. And of late, they come up with these restrictions of movement. They cannot take the selfie, which is a big problem. So we look at the movements, which should be done actively by the patient, and then you should try to do it passively. So you have to compare both the active and the passive movements. So by definition, adhesive capsulitis, it is an insidious onset problem, and pain is on isolated passive movements, or there can be sudden pain. There's a night pain, although the x-rays look normal. Now coming on to the second problem, the rotator cuff tears. So what happens in it? We normally ask a history, patient will give a history of fall, or it can be insidious in degenerative cuff tears. Normally they will have pain and weakness, which is contradictory to adhesive capsulitis, which have pain and stiffness. And again, we should not forget asking about the comorbid conditions. So this is a patient who had a fall and she was unable to actively move her right arm, but passive movements were possible. So to reach an appropriate diagnosis, we should take a proper history. We should try to make out a history diagnosis on what thing you are looking at, do a clinical examination, correlate it with the investigation, and then do a diagnosis which we are going to treat upon. So this is a quick exam. When we are examining the rotator cuff, we do it on a normal side, do empty can, full can, and look for posterior superior cuff. And then we do it on the affected side, and which is clearly positive for supraspinatus. And when we do an external rotation lag sign, which is again positive. So this is a supine Napoleon test. In case patient is not able to reach the back, this can be done very easily. When we ask them to lift up the elbow, they can easily do it. But if we do it on the affected side, it is not possible. So which is an indicative of subscap tears. So if we look at these patients, what are their characteristics when they have rotator cuff tear with stiffness? They are normally young aged, they are smokers. Normally they don't have any trauma history, and generally they come up with some partial thickness tears. And if we look at this analysis, which was done on 379 patients, in patients who had rotator cuff regions with stiff shoulder, they found out that 51% of patients had intact rotator cuff, only 35% had full thickness tear, while 15% of these patients had partial thickness tears. So the investigations which need to be done is to start from very basics, that is X-ray, because we need to look at the quality of the bone. If we are contemplating a fixation, we need to change our technique or switch on to the bigger anchors. Mostly they are normal, apart from the osteoporosis, if you can see. MRI, we have to look at the IGHL, which is normally it's around 4 mm, but less than 4 mm, but in adhesive capsulated, it is increased up to almost to 1.3 centimeter or more. In a sagittal oblique, there's a classical subcoracoid triangle sign, which is absent in adhesive capsulitis. And if we do an arthrogram, in normal arthrogram, we can see a lot of dye going into the shoulder, but in frozen shoulder, it's all, as the volume of the shoulder is decreased, it is less. Again, in MR arthrogram, they can be absent axillary recess. So there was a study published in this year, May 2020, which MRI findings which were predictive of a stiff shoulder in patients with full thickness tear, and they found if there's a joint capsular edema and the thickness of their thickness at the axillary recess, they have high chances of developing a stiff shoulder with a rotator cuff tears. So where is the problem? There are two ends of the spectrum. If we do a RC repair, rotator cuff repair, it needs to be then it has to be protected rehab to ensure tendon to bone healing. But if there is a adhesive capsulitis, we need to be aggressive during rehab. So this is a big problem. Which way to go? What to do? So the treatments can be like do a pre-operative rehab and then do a rotator cuff repair, or you can do a concomitant rotator cuff repairs and a capsular release. So looking on to the first part, rehab pre-operatively and doing a rotator cuff repair. That consists of various things. You can do an intra-articular injection into the glenohumeral joint and then mobilize the patient, or you can do manipulation under anesthesia, but it has its own problems. There can be post-manipulation stiffness and pain, and there can be fractures, which is the most dreaded complication. So the problems with the rehab pre-operatively is there's a prolonged duration of rehab, and most of the movements, they occur as scapulothoracic linkage rather than at glenohumeral joint, where we want the movements to happen. And there's non-compliance with the pre-operative rehabilitation only because of the pain and at times weakness. So what happens if we keep on doing a rehab? The problem can be, there can be progression of the tear, there can be fibrosis of the remnant tendon, or the muscles can get fatty infiltrated, which will make our eventual repair more difficult and challenging, which will be actually a royal challenge to us. So looking at the other part of the treatment, which is concomitant rotator cuff repairs and capsular releases, Yongal Ri in 2008, they looked at it. They looked at the functional outcome of arthroscopic repair with manipulation under anesthesia during a rotator cuff surgery, and they found out good pain relief, good range of motion, and muscle strength, which was even present after manipulation and doing a rotator cuff repair. Badri-Sawa, they went ahead and then they did a concomitant capsular release. They looked at 36 patients and they found out the UCLA score improving from 14.2 to 32.2 at 2 years. And even the movements were much better. So if we look at what is the relationship between shoulder stiffness and the rotator cuff healing, so in this study by George Muller et al., they looked at 1533 patients and they assessed the post-operative movements at 6 months, 12 months, and 2 years, and also looked at the integrity of the cuff with ultrasound. And they found out that if a patient had developed a stiffness at 6 weeks, they must be having an exuberant healing response. And if they came with pain at 3 to 12 weeks, they must assess it with ultrasound to look at most dreaded complication, that is re-tear of the tendons, which can happen if you are trying to rehab them aggressively. So if we compare both the treatments, which one to choose and which one not to choose, there are many studies which are looking onto it. A systemic review by Albert Lin group, they found out that concomitant surgery in a one stage with repair and capsular release gave good results. So there was no role of doing a physical therapy before a surgical intervention. And then Kim et al., they looked at whether delaying the surgery can improve the outcomes and did an analysis on immediate versus delayed surgery. So they found out there is no clear advantage on delaying the surgery. And even doing a rotator cuff repairs with capsular release saves time and it avoids unnecessary rehabilitation. And Andrew Sheehan group, they did again a systemic review which was published in 2018. And they have found out that whether you do a MUA or a capsular release along with a repair with accelerated post-operative rehab, they have found out very good results and there are no substantial increase in complication rate. So this is a case. She is a 45-year-old right-hand dominant female. She had a fall a month back. She complained of pain and stiffness, and she was uncontrolled diabetic. She was investigated further, but on clinical examination, she had total elevation which was around 70 to 80 degrees. External rotation by side was almost 0 degrees. Internal rotation was almost up to sacrum. So she had a rotator cuff tear with a stiff shoulder. If we look at the MRI images, the rotator cuff was torn and axillary pouch was all obliterated. So the plan was to do a capsular release and a standard rotator cuff repair with a double row transosseous repair. So this was her intraoperative video. We can make out that this even rotator interval tissue is thickened. So I try to come in and do a formal release with a scalpel. And then with a radio frequency wand, we can take out all these tissue. We have to be very careful. At times it is difficult to enter such shoulders who are very stiff. And the bone is porotic. You can land up entering into a bone. So with RF, you can just take out all the inflamed tissue. You can clear off the rotator interval. You can then you have to take out the MGHL and clear off the capsule. So you have to go in between the labrum and the muscle to actually see the muscle which is coming up, clear off all the tissue. If you want to go inferiorly, you can go inferiorly and do the releases, but you have to be careful about the nerve. And then you come back towards the CHL. CHL has to be taken from the base of the coracoid. You release it well to get a good movement. So this is very important. Although you do it all anteriorly, at times posterior releases are not required always because it is the posterior capsule is not involved much. And after clearing all this, you come back to the subacromial space and do your standard rotator cuff repair. I normally prefer a tension-free with a double row transosseous equivalent so that I can rehab them aggressively. So this is a standard subacromial decompression. In this case, it was a lateral acromion which was impinging, so I have to take it out. You can see the double row repair which has been completed, and a subacromial decompression as well. So this was a 6-month post-op. She achieved full range of movement. Total elevation was equivalent to the opposite side with good abduction, and it was pain-free. She went through all the rehab protocols. She was under a good watch. She was asked to follow up after every month or 3 weeks to have a good look at the rehab, which is very important. So the take-home message from this is we should not turn our cold shoulders in a patients with cuff tear and adhesive capsulitis, because capsular release along with the rotator cuff repairs can be safely done. There's no substantial increase in the complications. Adhesive capsulitis, in fact, helps in healing the cuff, which should always be followed by aggressive rehab. Thank you.
Well,
Dr. Inderdeep?
You have just nailed it, I would say. An excellent presentation on a very, tricky topic, I would say. Let's have the opinion of the house that how do they tackle the situation. Let's go from up to down. So all the seniors, Dr. Samantha, you start and ask the others. How do you tackle such a situation?
No, you see, the problem in our country is that whenever the cough comes, usually they are a bit stiff. So it is always a problem whether to go and
full-blown rotator cuff, full-blown frozen shoulder with rotator cuff. Not we have this situation. How do you deal with it?
No, if it is a full-blown cuff tear, I think you must go ahead with first the physio, because in the problem is that if it is a full-blown stiff with a cuff, then it is very hard to go ahead. Because at least you should try the physio for minimum 6 weeks time. You can give at least, as I have already been consensus, that one sort of steroid you can give. The problem is at least only one sort you can give, at least regain some movement. Otherwise, very difficult to enter, very difficult to do the cuff repair, and very difficult to go ahead with the post-op physio. So problem is that first you regain some sort of movement, then you go ahead with your cuff repair, then you can do your proper job. And when you do your cuff
rehab followed by surgery.
First, you go ahead with your intra-articular, release whatever is possible from intra-articular. Otherwise, your cuff won't be mobilized.
So for you, first rehab, then surgery at the second stage. This is a type. Okay. Sir, Dr. Ravi, sir, how would you proceed? First type or second type? First surgery or first rehab, sir?
I think the first thing is we have to make out what is the main problem. As Dr. Samantha said, many degenerative tears, they have some kind of stiffness. So sometimes it is difficult to differentiate what is the main cause of the problem. So I determine whether the main cause is adhesive capsulitis. In those cases, the pain is the main element. Patient is able to lift the shoulder up to 80 to 90 degrees, but the scapula starts moving even the moment you try to move the elbow. So you have to keep one hand on the scapula and then try to move the shoulder. You will feel that the scapula is starting moving immediately. And the patient's main problem is pain. So in those cases, MRI also shows tear along with this, adhesive capsulitis. In those cases, I first give an injection. And majority of my patients, they get pain-free. Some of them, they get pain relief only temporarily. Those are the patients where I can think about the second surgery. So I always try conservative treatment first, a shot of steroid. Usually single steroid is enough, as Dr. Samantha said.
Only one dose.
Yeah.
Okay, sir. Dr. Sudhir.
Sir, if a patient is uncontrolled diabetic, will you prefer giving a steroid?
No, that is a different issue altogether, because if your diabetic is not controlled, it is very difficult to go even for the surgery.
So can I ask the question like the Samantha has already asked? If the patient has uncontrolled diabetes, what do you do for surgery?
Yes. Surgery is the medical issue.
Which is easier, giving the injection is easier or doing a surgery is easier in diabetes?
Diabetes, either way, we have to control the sugar.
Yeah, we have to control, but surgery, I think, have more complications, life-threatening also.
Yes, sir. Dr. Sudhir, can we have your opinion, sir, on this topic?
Sharad is also waiting. Siddharth, Sharad is waiting for a long time.
Dr. Sharad, please go ahead. What's your take on this?
Thank you, Siddharth. I would just like to offer two comments. One, because it's a fairly upcoming concept, and our older teaching has been to do it in a stage procedure. Even the newer papers that are coming in, they talk about a disadvantage of like doing a manipulation under GA for frozen shoulders, saying that it may increase the cuff tear, or any other surgical procedure that you're doing two surgical procedures. So I think that kind of like misses the mark. What we try and follow is like a middle path regime. We know that once a patient is booked in, he's going to come in like 8 weeks or 10 weeks after surgery, because that's how the dates work. So we do a subacromial injection. So not subacromial, we have suprascapular nerve block for the patient. We get them on passive stretching, and that usually takes care of the pain. So you have a fairly mobile patient by the time the patient presents to you for surgery. And that sort of takes care of the initial part. He's waiting, he might as well do passive stretching. The severe pain that he has with the nerve block takes care of like 80-90% of it, and they're compliant in that ways. And so you get out of this. Regarding the question regarding diabetes for doing an injection, I think in that way, a nerve block is a way out, because you're not injecting near the joint, you're not injecting the joint itself, you're putting your drug near the nerve. And so you are avoiding two things. One, you don't have to defer your surgery, like for more than 10 or 12 weeks. It's not like you're waiting until your blocks takes effect. And at the same time, you're not worried that you might cause septic arthritis or something like that. So that's my take on it. Staged, but smartly staged.
Dr. Rajnish.
Yes, Mantha, as Dr. Ravi has already said, that I always do a two-stage. Like first, I always try conservative. I try to mobilize, because it is really, really very difficult to differentiate whether the adhesive capsulitis primarily or it is the stiffness is because of the rotator cuff tear itself. So I always try to mobilize it, give sometimes an injection, and regain some movement. I don't do like the concomitant sort of a capsular release as well as a rotator cuff repair at the moment. Maybe in the future may.
Okay, so we have till now the poll is 4-0 in the favor of conservative after and then later stage surgery.
Staged one, and it is a big no for the manipulation. Please remember this from the podium. Don't manipulate your shoulder if you see that there is stiff and there is a cuff tear. You are doing more harm than good.
Okay. Anybody disagreeing with this in your talk?
I will be on the.
You have been on the receiving end now.
Dr. Pandher.
I will still on the doing a concomitant rotator cuff repairs with the adhesive capsular release, not manipulating it, but that definitely gives us an advantage of not wasting much time or waiting for 6 weeks. And then I just want to know, like Dr. Samantha sir said that we would like to get some movement. What do we mean by some movement? Is it like 90-degree movement, or how much external rotation?
No.
Are there any special techniques you follow for getting these movements in? Or you just leave it to your physiotherapist to do the magic?
Siddharth asked the question. He asked whenever it's completely stiff shoulder with it was not like 30-40 or whatever. If it is a completely stiff shoulder and MRI, you see that there is a cuff tear. The patients have come to you not because of the cuff, because he is not having anything. He is come only because of the two issues. One is the pain. Second is your stiffness. So first, if you take care of those, then only it is easy. Because if you read the Body Savoy's paper, he told that is a cuff tear with the stiffness. You have to go ahead intra-articular. You have to do 270-degree release of your capsule. Then only you can repair the cuff. Otherwise, you cannot do the cuff repair.
So
you're right,
that is what Inder is saying, sir. Inder is saying that we release the whole of the capsule and do the cuff repair concomitantly. That is what he's doing.
Yes. But if it is completely stiff, it is very difficult to go ahead. Even because
means that you can say the patient had a cuff tear and he was troubled, and in the meantime, trying conservative, the patients many times become stiff. That sort of picture. Because when they are in conservative, they sometimes end up, giving more rest to the shoulder. So that is the situation actually we end up with. That he was having a cuff tear, some degrees range of motion, and ended up in a frozen shoulder consequent to that.
Okay. I think go ahead with the. Now we can move ahead with Siddharth. So with the next topic. Final comment for Pandher.
Yes, no, I'll be very quick. It is actually, if you are dealing with a stiff shoulder or a frozen shoulder and a cuff tear, we'll just think about the frozen shoulder. The frozen shoulder that we come across in practice are of two types. One are stretchable, who will start improving with 3 weeks of stretching. And one are like recalcitrant, they'll not budge to any kind of stretching. And this is what I see, that I put them to exercise. Some will give good results, some will just not find any change after a month. So to conclude, the kind of shoulder that ID has shown, this was a recalcitrant type of adhesive capsulitis. And in my personal experience, no amount of stretching or rehab will give you a good result or give you any kind of motion in this shoulder that he has shown. But otherwise, we come across stiff shoulders that are stretchable, and the stretchable shoulders, they do well. And in those shoulders, even if you do the repair and do a little bit of release and you just start them on rehab early in comparison to your routine rotator cuffs, it works. But the shoulder that ID has shown, believe me, your stretching will not work in this kind of adhesive capsulitis.
One comment from Dr. Manish Bansal. Sir, Manish wants to jump in, sir.
Earlier, when 8-10 years ago, my bosses in England would do any kind of stiff shoulder with cuff in 2 stages. First stage would be to either release a cuff, capsular release arthroscopically, or to do a manipulation, or to do a stretching in the OPD. And then in second stage, do a rotator cuff repair. Gradually over the years, things have changed. Now it's more aggressive, like ID is doing. If the shoulder has to be done, either capsule release or manipulation, it can be done at the same sitting as cuff tear. Things have become more aggressive now. So more and more younger surgeons are doing both things in one sitting. Like Dr. Pandher said, this shoulder is not going to improve on conservative management. You will have to do something intervention. The question was, will you do that surgical intervention in 2 stages or 1 stage? Now more and more people are going in 1 stage, that in 1 stage do capsule release and do the cuff repair, and the results are pretty acceptable in long term.
Yes, Dr. Manish, I completely agree with that. But one thing I just want to give one comment. The stiff shoulder along with the cuff repair is probably the stiffest surgery around the shoulder. So be very cautious, and unless you have done at least 200, 300 cuff repair, then you should not go ahead with your completely stiff shoulder along with the cuff to repair. You will be in trouble. The problem is that you won't be able to enter into the joint. That is the main issue.
I think Samantha sir has said it rightly, and Dr. Sharad, what he is talking about, suprascapular nerve block. I think that is something that will be help. Dr. Sharad, in your talk, I think we'll elaborate more on that.
We'll come on to that talk. Yeah. Okay, go ahead.
And then we'll discuss about that point. I think that is a very valid point in such scenario. For the timing, sir, let's move on to Dr. Rajnish talk.
Go ahead.
Capsular release and adhesive capsulitis, sir. Dr. Rajnish, sir, please continue.
Yes, good evening, everyone. Dr. Samantha, Dr. Siddharth, my dear friend, Dr. Ravi, thanks for inviting me here and giving me an opportunity to share my viewpoint. So I would be speaking on anterior capsular release in adhesive capsulitis. Adhesive capsulitis, the incidence is in 3 to 5% in general population, but then increases to 20% in diabetics. So more than 90 to 95% patients, it's like a common self-limit, as we know, is a self-limiting. With a conservative treatment, 90% patients are going to improve in 1 or 2 years. Physiotherapy alone, I want to stress upon this point that certain of our physiotherapist colleagues, they are very commonly misguiding these people that physiotherapy alone have a very little value. So it has to be associated with other some analgesics or a steroid or intraarticular steroid injections. But in spite of this, all these efforts, 5 to 10% patients those who are not responding to the normal conservative treatment would need some kind of a surgical intervention, those who have a recalcitrant type of a disease. So the stage 1 is it's an early stage when we have a 0 to 3 months of duration. Naturally, the patient will be having a pain and limitation of range of motion. Arthroscopically, if we see in stage 1 that there is in stage 1 there is a synovitis. You see the synovium, there's a reddish tinge there. Okay, the more of synovitis on the insertion of the biceps there's along the rotator cuff interval, anterior capsule and the posterior capsule, there's synovitis there. when we progress to stage 2, freezing stage is 3 to 9 months of a duration. There is a chronic pain, the pain and stiffness definitely will increase. But when we see intraoperative arthroscopically, there's a huge synovial hypertrophic there. Hello, yeah. So there's a lot of synovial hypertrophy. There's a villous type of a synovium, and sometimes there's an obliteration of the rotator cuff interval there. Okay, so you see a lot of synovial hypertrophy formed like synovitis in the rotator interval in stage 2. And once we proceed to the stage 3, there's a frozen stage. The duration of symptoms are like about 9 months to 15 months. Now it is in a chronic state. But if we see arthroscopically, now the synovitis has decreased. The volume, the capsule is contracted, and there is a volume, there's a decrease in volume of the shoulder joint, but synovitis has decreased. It is now decreasing. And then you see the glistening and a waxy type of appearance of the synovium there intraoperatively. And then we have a stage 4. So most of these adhesive capsulitis, they're going to recover in 2 years, but 50% of the patients, they will have a mild pain at 7 years, and 60% will have a persistent, some sort of a persistent stiffness. And out of these, post-traumatic or post-injury, post-traumatic patients are more resistant to the conservative treatment. So treatment options, we have a physiotherapy, steroid injection, manipulation under anesthesia, distension and arthrography, and arthroscopic capsular release, from which I am going to speak on today. The advantages of arthroscopic capsular release. So the one of the biggest advantages that when we put in a scope inside, we can see we can confirm the diagnosis, we can see other pathologies in the shoulder joint, other potential causes of the painful stiff shoulder. So it allows us to directly visualize the tightened ligaments and the capsule and do the adequate release. So we can directly visualize the structures there. And then it is a controlled release of the capsule, contracted capsule and the ligament. It is effective, it is safe, and results are much more predictable. Because when we burn the capsule with the electrocautery, it allows us for a delayed healing. So when there is a delayed healing of the capsule postoperatively, so with aggressive rehabilitation, we are able to regain a pain-free good range of motion. So these are all advantages of arthroscopic capsular release. So indications, when do we actually go for arthroscopic capsular release? So mostly it should be a well-performed 6 months of rehabilitation program. If patient is not responding after a well-performed rehabilitation program, it's not responding, and patient's pain, stiffness, all these symptoms are persisting for a long time, then that is the indication. And then after 3 steroid injections with a 6 months of interval. So this is the main indication for the arthroscopic capsular release. Then some patients who wants an expedited recovery, or there's a contraindication for the steroid treatment. So there is always a subset of patients, those who we have a very low threshold of pain, or they would not go for rehabilitation, physiotherapy, whatever we do. So these are the kind of patients you have to choose very carefully, and then if you go for an early arthroscopic capsular release, you may have a good results in these kind of patients. Contraindications, so same that non-surgical treatment should less than 6 months. And then if the stiffness, very importantly, you have to get an X-ray, you have to get all the investigations done. If the stiffness is due to any other reason apart from the adhesive capsulitis, then if it is because of osteoarthritis, or if there's a rotator cuff arthropathy, then this is a contraindication for going again for forward like anterior capsular release, and if there is any evidence of a active infection. So these are the contraindications. So I would like to touch upon this because manipulation under anesthesia, because many of us before starting this arthroscopy, we also used to take these patients for manipulation under anesthesia. But there are definitely, now we have learned that there are many disadvantages of this forceful maneuvers. Like we have seen bone fractures, rotator cuff tears, all these labral tears, lap lesions, all this extensive soft tissue trauma. They have been mentioned, they have been written in the literature that a patient has undergone all these complications with the manipulation under anesthesia. So advantages of anterior capsular release over manipulation under anesthesia is that it is more precise and controlled type of a procedure, and it is safe also. You can see the structures as I have told earlier also, that we can see the structures directly in front of us, and then in a very controlled fashion we can release them, rather than going for a blind sort of a traumatic type of a procedure. And then when we do a manipulation under anesthesia, then it sometimes increases further adhesions because there's an intra-articular bleeding there. But when we cut it with a radio frequency probe, this capsular release, there's a delayed healing, and it allows us for early post-operative rehabilitation and immediate relief of the pain. Surgical technique, so you can take either in a lateral decupitous position or in a B-chair position. The portal placement is on posterior, then we have an anterior lateral portal which is made just anterior to the biceps tendon, and then we also make one lateral portal also for the subacromial decompression, which I will describe later. And radio frequency device, it is a mostly L-shaped or a 90-degree angled radio frequency device. So then first and foremost important is that when you do this anterior capsular release, you have to first identify all the structures which you have to release, and then first step you release in the rotator cuff, you go in the rotator interval and superior glenohumeral ligament and the craccohumeral ligament. This craccohumeral ligament is the most important structure which you should identify and release it, because this is the most pathognomic structure which causes the maximum the stiffness and external rotation stiffness. So until you see a vertically oriented fibrous of the craccohumeral ligament and the conjoint tendon, you have to completely release this superior glenohumeral ligament and the craccohumeral ligament. So this is the craccohumeral ligament. This starting from the base of the coracoid craccohumeral ligament and then going towards the bicipital groove there. So you have to intra-articularly identify this in a rotator cuff interval and release it. And then you go ahead and release the anterior and the inferior capsule. So you have to release the middle glenohumeral ligament and then go inferiorly and release the inferior glenohumeral ligament and the inferior capsule between 5 and 7 o'clock position. So a subscapular is also the tendon. There's a little bit of controversy that whether it should be completely released, but most of the authors these days, they are releasing the intra-articular subscapularis tendon, also part of intra-articular part of the subscapularis tendon. So this is how, when you put in put a scope from the posterior side and the instruments from the anterior lateral portal, you see that this is a craccohumeral ligament. So there's a lot of synovitis there. So this is type of a picture which you'll see initially, that it is a reddish synovium, hypertrophic synovium there. But once you do the synovectomy, you ablate the synovium, so you are more clearly you can able to identify once you debride the synovium and ablate the synovium there. So you see that there's a craccohumeral ligament there, then there's a subscapularis tendons there, and there's a long head of biceps there. So this is a rotator cuff interval which you have to identify, and then you start cutting, ablating these structures, craccohumeral ligament and the glenohumeral ligament, and slowly coming down the subscapularis tendon there. So this is after release, you see that you have released these structures, and then suddenly there will be a lax sort of anterior capsule, and you have a more space there to work. So then it coming to the posterior capsule. So it again, there is a little bit of debate here, that debatable point, that whether you should release the posterior capsule or not. So to see this, you have to actually very importantly pre-operatively assess the range of motion. You have to very carefully examine the patient. If the internal rotation and the adduction, they all are also significantly, there's a stiffness there. So then only you should actually release the posterior capsule. Otherwise, you can just go for a anterior and the anterior inferior and anterior superior release, and you can like try to preserve the posterior and posterior inferior capsule. And chances of the axillary nerve injuries are also increasing when you go for a posterior inferior release. So this is how you can go. And when you do a posterior release, you have to switch on your instruments. Now your scope is in the anterior lateral side, and your working instruments are from the posterior portal, and then that's how you actually release the posterior capsule. So axillary nerve, you have to be all the time very, very careful about the injury to the axillary nerve, because this nerve is much vulnerable when you're doing the inferior capsular release. This is just about, it's towards the humeral head, this axillary nerve. So when you are looking into the joint, it is towards the humeral head, 15 to 20 millimeters from the glenoid, the edge of the labrum, but it is only 2 to 4 mm below the inferior capsule. So you all the time you have to stay close to the labrum, the glenoid edge, so that you can avoid the injury to the axillary nerve. So, and then you can also stretch the arm in abduction and external rotation. Thereby, with this maneuver, you are actually putting the nerve little away from the arm stress. So your electrocautery tip should always stay within the 10 millimeters of glenoid room and near the glenoid labrum. So this is how actually you do the inferior capsular release. So you should release near, this is a labrum, so you should be staying very close to the labrum there. So then subacromial decompression, this is usually done as a part of the procedure. So you go and from the lateral portal now and do all the lateral subdeltoid bursectomy, and crococromial ligament also sometimes is released. So it is also source of the rotator cuff irritation there. Chromioplasty, there's no need to do a formal acromioplasty in most of the cases, because there's if you do a lot of acromioplasty, there'll be bleeding there and it will result in a reactive inflammation, which will be a source of post-operative. It will give you a poor result and increase the stiffness post-operative. So you should do avoid doing the acromioplasty, but you should only do the subacromial decompression. And post-operative rehabilitation is very, very important. So your whole results are dependent on the rehabilitation. Once you have released the capsule, you have to personally supervise and go for an aggressive rehabilitation. But believe me, so most of the patients, once you do an adequate release, there'll be immediate relief post-operatively. The pain will be relieved, the shoulder will be lax, and patients which were very reluctant to go for a physiotherapy perioperatively naturally will be more compliant to do a rehabilitation. So you have to have a very aggressive post-operative rehabilitation program. So the key point in the surgical technique, the take-home message is that it's not necessary to do it in a regional, this general anesthesia. Even the regional anesthesia can also be used. Interscleral block can be used. The pre-operative and post-operative range of assessment is very important. You have to do the pre-operative and post-operative assessment and document also in a conscious patient. Adequate release in the rotator cuff interval is performed focusing on the craccohumeral ligament, which is the most important target. So the care should be taken of an axillary nerve injury. You have to always be careful, keep it in mind, and always avoid injury to the axillary nerve. So you can actually, as I've told, you can take the arm into abduction and external rotation so that the capsule gets stretched, and this makes this step a little easier. And post-operative rehabilitation program is which is very important. You have to supervise very carefully. Thank you very much.
Thank you, my dear friend Rajnish. Any question from any of the senior faculty or any explanation, anything to add on?
I'll just say that this surgery can be highly satisfying and it's very simple also. So when I started my shoulder arthroscopy in the year 2001, this was the first surgery I performed. And the patient was so happy. He was admitted in one of our private rooms. I still remember, as Dr. Rajnish was presenting, exactly, he has given a very beautiful pictures and of the surgical technique. So this is what I did. And the patient was so satisfied the next day. The night pain was gone the same day. So this can be highly satisfied surgery, provided the selection of patient is good. Yeah.
Yeah, in my this experience also, like I've done about like 25 this anterior capsular release now in last 3-4 years, and I've seen that if you choose your patients very, very carefully, and those patients, those who are really really dejected and they are recalcitrant type of a patients, if you do the surgery in those patients, the results are very, very satisfying, and they immediately get a post-op relief in the range of motion also and in pain relief also. And one more thing I wanted to add, that in this I saw gone through the literature, and in this, like most of the authors from the recent literature also, they have shown that if you have a adhesive capsulitis along with the rotator cuff, significant rotator cuff tear, so it is better to go for a two-stage surgery. First, you go for an anterior capsular release and get a good range of motion, let the patient recover from that surgery, and then as a second stage, you go for a rotator cuff repair. So it was very interesting discussion earlier
I
also.
think Dr. Rajnish is absolutely correct, because in many elderly patients, these degenerative tears may be just incidental.
Yes.
And after you release your shoulder from adhesive capsulitis, they may not require a second surgery.
Yes, of course. Yes, I think they may not require the second surgery also.
Thank you.
So I think this is a Pandora box of stiffness, repairs, releases, and always a question, and we are all continuing to learn. So far, the house goes in favor of two-stage thing, either by rehab or a surgery. First, take care of frozen shoulder, and then, if required, head towards the rotator cuff. So far, the house is like that, and so far so good. Thank you, Dr. Rajnish. You did a very great step-by-step explanation of how to proceed with the surgery and also how to protect the axial nerve. Sir, one question from the house. Anybody of us have anybody of us has ever had a axial nerve palsy in shouldroscopy till now? So just anybody. I've heard everybody being cautious, but has anybody actually had one?
No, axillary nerve palsy is extremely rare, because you think if whatever you are doing with the radio frequency. And when you go around the 6 o'clock, automatically you just stop. Unless you go beyond 1.5 centimeter from the 6 o'clock position, it is very, very hard to hit the axillary nerve itself by your probe.
Sir, I think 1.5 centimeter is a bit overestimation. What do you say, Manit?
It is not very close just at the 6 o'clock. It is 1.15 millimeter, 10 to 15 millimeter away from your glenoid, where the 6 o'clock is actually intra-articularly, I tell you. It is not that close. Unless you just take off the whole capsule at 6 o'clock, then only if you go ahead with your radio frequency probe, then only you are going to hit the nerve. Otherwise, it is not very easy to hit the nerve.
That's why actually some authors are saying that it is not a good idea to go for a 360-degree release. Actually, it is adequate if you can just be releasing the anterior capsule, anterior inferior, and the rotator cuff interval. And if you want to release the posterior capsule also, you just do a posterior superior release rather than going a posterior inferior and then that 6 o'clock to 9 o'clock position. So you try to avoid releasing that kind of this thing. Don't go for a 360-degree global release.
Okay, sir. Mukul wants to say something. Mukul?
Sir, is there any consensus of what should be done to the biceps in such cases?
In frozen shoulder releases?
Yeah.
No, if biceps is the condition of the biceps tendon is all right, I don't do tenotomy there. If this is really frayed or something, then you can go ahead and do the tenotomy. But if it is the condition of biceps is okay, you just go do the anterior capsular release or the capsular release, posterior or anterior, whatever.
Well, this problem in the biceps, in the cuff, this frozen shoulder is a very big issue, because you have to probe ahead the whole biceps, the intra-artic, what is the group part. It is known as the lipstick synovitis. It is completely been synovium. It has been whole covered like lipstick synovitis. The age is more than 60. Then probably you take off, because once you take off your biceps, 50% the pain relief is done post-op. So biceps is not the issue here. Problem is the age and what is the condition of the biceps fraying and the synovitis, how much is around. Then only you decide. There are so many issues. It's not like every frozen shoulder you go in and take off the biceps first. Okay.
But every frozen shoulder, I fully agree with Dr. Samantha that you don't take off. But in every frozen shoulder, as Dr. Rajnish has shown us the pathology, and Dr. Samantha also said that there is a lipstick kind of synovitis around the insertion of biceps. What I do is I take the probe of electrosurgery, which is, flat kind of a probe, not the hook type of, and then I just rub it around so that the synovium is gone.
Yes.
So synovial inflammation is gone around the insertion site of the biceps. So that I think should be done in every case.
Yes.
Yes, very rightly said, Dr. Ravi. Actually, very rightly said. Actually, ablation of the synovium is actually the first part of the doing an anterior capsular release. First, you have to ablate or debride or take off the synovium from all around, and then go start with the capsular.
I just make a small comment on this lipstick synovitis of the biceps, because these we learned from the great paper from Laura Lafos, because he told that the most pain generated in the biceps, the part of the biceps which is in the groove. So always take your probe, take the biceps intra-articularly, see how much the biceps in the condition in the groove. Because if you don't examine that, then the patient won't be satisfied.
Okay. So I think that concludes this talk, and going ahead, the talk on
But now I will seek pardon from you. I am going, right? Okay. All the best for the next two lectures.
Thank you, Dr. Ravi. Thank you for sharing your valuable time with us. Thank you. It was very nice to see you again.
Thank you, sir. Dr. Sharad, another difficult topic, another thing for research: suprascapular nerve blocks versus subacromial injection.
I will break a secret between me and Sharad.
Okay.
Before Sharad goes into his screens here, because Sharad and me, you will be knowing that we are AO faculty from trauma to arthroscopy.
Okay. Okay.
I just, sorry, Siddharth, can you see my screen?
Yeah, sir, your screen is visible and you're audible. You can start, sir.
So first of all, I would like to begin by thanking the Indian Arthroscopy Society and the Punjab Orthopaedic Association, and Siddharth in particular for having me here in front of such esteemed faculty. So just wanted to talk about a study we were doing regarding suprascapular nerve block versus subacromial injection for frozen shoulders. And we can talk about it later. It actually started out because we were doing suprascapular nerve block for cuff tears. And I would like to acknowledge Professor Mandeep, who's a mentor, Dr. Vivek, who's a resident who did a lot of the work, including following up the patients, Devinder, and is my co-consultant. Deepak is also a consultant with us, and these are the guys who helped us. No disclosures relevant to this. So we are well aware of this, that it's a common cause of pain, frozen shoulder, prevalence is 2%, up to 20 to 40% in diabetics. And now defined as not only functional restriction, but also extreme pain with restriction of both active and passive motion of the shoulder, and essentially your x-rays are normal. So again, this has been discussed that diabetes is a risk factor and prevalence is increasing. It has been thought to be self-limiting, but recovery is incomplete if you leave it. And it causes significant morbidity because of pain and restriction of functional activity. So that we want to decrease the pain, increase the ROM, improve function, and there are multiple options available how you do this. Just a bit about the nerve. It's a C5, C6 nerve root, and C4 sometimes in 18%, and it supplies enters supraspinatus fossa, supplies supraspinatus muscle. Then along the curve, the spinal glenoid notch enters the infraspinatus fossa. So two joints supplying the shoulder and the AC joint, supplying the supra and the infraspinatus. And if you block this, it's a mixed nerve, so it helps with your pain relief as well. So it's nothing new. It's described in 1941, and actually the pain clinic guys do a lot of this. So they are doing it in RA pain, rheumatoid arthritis, shoulders, also in post-op pain, and we as orthopedic surgeons find use in adhesive capsulitis and even in bursitis. Simple and effective, but certain landmarks. So we are using a combination of two techniques. These are landmark-based techniques. You can also do C-arm-based techniques. You can also do ultrasound-guided techniques. And any amount of debate goes on between whether an ultrasound-guided or a CT-guided technique, is it better than landmark-guided? That is not so. Several studies have shown that landmark-guided techniques are as effective. However, good to practice with the CT-guided or ultrasound-guided technique before you actually progress to a landmark technique. So one is the Mayer's technique, when the patient is sitting with both the arms in adduction. And you can see the landmark hits 2 centimeters above and medial to the midpoint of the spine of the scapula. And the direction of entry of the needle is towards the coracoid. So actually, when you put it in, you hit the bone and then you walk the fossa till you just are about to slip off it. That's where your notch is in the direction of the coracoid. Though the volume written is 9 ml, we actually are putting 5 ml through this. So we draw one syringe of 9 ml of lignocaine and 1 ml of 40% triamcinolone, and half the amount we give through the Mayer's technique, and the other half through a lateral approach. So this landmark is similar to the Neviceus portal, the soft spot, and you go down towards the coracoid, towards the base, aim it towards there, and you inject the rest of the 5 ml here. So this is one of the studies. Before we started doing this, we injected dye. So the larger part of the black dye that you can see is from the Mayer's technique, and it really fills the supraspinatus fossa even if you miss the nerve. Now this is to the Nevese portal and more targeted approach. It targets the nerve at the notch. And the advantage of sort of dividing the volume between the two approaches is you are not overloading anywhere. If you give too much in the Mayer's approach, you can have patients who are dizzy, giddy, and there's a brachial plexus over there. You can have issues with that. And it sort of divides the volume amongst the two approaches. So essentially, you're flooding a supraspinatus fossa with about 10 ml of local with triamcinolone. So it's relatively safe and effective and can be done on an outpatient basis. But you have to be aware, you have to talk to the patient, consent them before. They all have transient dizziness. A lot of them have flushing. Some even have a vomiting sensation. If you're not careful and you're not trained in putting the needle in the wrong direction, you can cause a pneumothorax. And failure to recognize that you have caused a pneumothorax can be devastating. You can cause intravascular injection or a residual motor weakness, especially to the Mayer's technique, if you inject very close to the brachial plexus. And for any injection, you can have a vasovagal response. We are all familiar with the subacromial injection. I like to do it from the back. Some like to do it from the side. Others like to do it from the front. And this is a technique which any orthopedic surgeon does. And this is, again, we took a C-arm with that. We injected it and then took a picture to see how well it fills up. And if you get to actually move the arm around, you'll eventually find a dye fills up the subacromial space. So it's simple and safe and easily done as an outpatient procedure. Rare complications, you may end up injecting the cuff, which is unfortunate, but so don't do that, put it in that space. So obviously it's contraindicated, uncontrolled diabetes, uncontrolled coagulopathy, don't do it. Don't inject the cuff. And if you inject it under the skin, it can cause issues, atrophy of the skin, hyperpigmentation, and fat atrophy. So this question was asked to me that why are you doing a subacromial injection? Why not an intra-articular injection? It's been well established. There's no difference in results between intra-articular versus subacromial injection. And so we want to avoid an intra-articular injection to avoid all cartilage issues and stuff like that. I don't want to end up with septic arthritis. So the efficacy of being almost similar. And right for any injection, whether you're doing subacromial or you're doing a nerve block, a specific informed consent detailing all possible complications. And you'll have patients suing you otherwise that you didn't tell me this would happen, that would happen. Have an IV cannula and a saline drip running, especially in an apprehensive patient, especially you have a female, middle-aged, who's never had an injection before, probably best idea to have an IV access. Please have an assistant ready to help in the event of an adverse reaction. So you can do this in an OPD setting, provided you have at least an IV drip running and be prepared if you have a vasovagal. So in our study, the research question was, is a suprascapular nerve block more effective than a subacromial injection for improving the functional outcome of frozen shoulder? And the null hypothesis was that there will be no difference. So we had initially planned for 70 patients to be taken up till December 2020. We managed to enroll up till 47 because of the whole COVID thing. And out of these, only like 7 were diabetic controlled, which was surprising. We're expecting more of diabetic patients here. And all skeletally mature adults, idiopathic or secondary to small cuff tears, and normal radiological appearance and X-ray. We excluded any obvious arthritis, any brachial plexus injury, stroke, post-traumatic, post-surgery, or those who have had a similar procedure done 4 weeks previously, or those who did not consent. So a fair number of females, like 70% are supposed to be females. It's not 70%, but about 60% are females here. Distribution among the groups about 25 and 22 in both the groups. And they were randomly divided using random number tables. Followed up with 3 weeks, 6 weeks, 3 months. So for 3 months, we have complete follow-up. For 6 months, we have about 50% follow-up, again, because of the COVID thing. But the reason I wanted to present this is because the results are significant. So the orange curve is the suprascapular nerve block. And so there's a lot of very sharp fall in the curve. And there's significant difference in pain relief in at 3 weeks, at 6 weeks, and at 3 months, as far as the suprascapular nerve block is concerned. And what we do expect is that at 6 months, however, this difference will finish because we have only 50% of the patients and the grafts are meeting here at the 6-month point mark. And this is because this is the time we expect that the patient has recovered his range of motion, doesn't have any pain, and is doing well. Second is a simple shoulder test did not show any statistical difference between the two. Both the groups did well. Constant show did not show any significant improvement, but there was significant improvement in forward elevation at 3 months. But again, the difference finishes at 6 months when you get back full range of motion with either technique. Again, external rotation significant at 3 weeks, 6 weeks, and 3 months, but at 6 months it is not significant. And internal rotation, again, significant at 3 weeks, 6 weeks, and 3 months. But by 6 months, everybody gets back their internal rotation. There's still a study in progress. As we are adding our case numbers, we might have more significance at 6 months, but it is what we expect. that yes, at 6 months, you will get back your range of motion, your pain will finish. So irrespective of whether you have done a nerve block or a subacromial injection, if you have patients doing physio and they're stretching, this was done for both the patients, and you'll eventually, your shoulder should open up. So what was the advantage? The advantage was a very steep decrease in pain and early improvement in shoulder motion in the early weeks of follow-up, and up to 3 months. And this is the time when you are getting them to focus on the rehab. And first we start with actually assisted stretching of the shoulder. And once they get back their range of motion with stretching, with passive stretching, then we put them on to a strengthening protocol. There's no difference at 6 months because, again, like we said, we expect the shoulder to open up. So from my side, the take-home message would be consider a suprascapular nerve block in patients who have failed previous subacromial injections. Like you've had history, they've had 1 to 2 injections. You don't want to put more steroid in the joint. Do a suprascapular nerve block. Again, uncontrolled blood sugars. We've done this for diabetic patients as well with relative amount of safety. Nobody's come back with septic arthritis and stuff. Associated cuff pathology, if you're anticipating cuff repair. And this I talk about, we initially started doing suprascapular nerve blocks for elderly patients who were unfit for surgery. And by addition of triamcinolone to xylocaine, and they have pain relief for a year. So again, very effective for cuffs that you cannot manage initially by just arthroplasty because of whatever PAC issues and all. But the caveat here is that, and again, very severe pain. So we must practice it under supervision and imaging. And once you get the hang of it, then you do it with the landmark-based method. Pneumothorax, I would just like to caution, is uncommon but deadly if unrecognized. Thank you.
Thank you, Sharad. Excellent talk as usual.
Thank you, sir.
But you have to teach us how to give it cautiously, because probably you take your radiology colleague with you, or you yourself do it.
So no, we're doing it ourselves. Because the only thing that you can usually hit is just bone. So when you are putting that needle in, you're usually just hitting the supraspinatus fossa, the scapula. The trick is that when you are walking that supraspinatus fossa, to make sure you don't advance that needle when you just go off the edge, because then you will end up puncturing the lung, which is something we don't want to do. So again, like I said, you can visualize this when you are using a C-arm. With the patient in sitting position, you can put their arm in and see, and you can actually see where your needle is going. Or better still, have your anesthesia consultant show you with the ultrasound as to where the needle is.
That thing I'm asking, because if you take your anesthesia colleague in the OT and he guides you with your injection, I think that will be better, because so many complications can happen with the pneumothorax, vomiting, dizziness, and all this. And already we have been stressed. So better not to stress ourselves much more.
Sir, so once or twice, like you may have an anesthesia colleague, once or twice you do it yourself with a C-arm. So if you've done like 10, 15 injections or 20 injections, that supervision becomes easy. I have done a lot of these. I have done like
next time, whenever I will meet you, you have to teach me. This is you have to promise me.
I promise you, sir. And, just my only concern, and what like everybody is drilled into me is this: that don't cause a pneumothorax that you don't recognize. So before you actually inject your solution, aspirate and see. If you're just aspirating air, you are in trouble.
Okay. Dr. Sharad, one thing. What's your opinion about this injection in case this suprascapular nerve block in case of subacromial bursitis?
So I have not actually given it in subacromial bursitis because I've not had a patient so far. It has been like mentioned in books, you can do it. Like for any other pain, I cannot understand the reason. Maybe it's uncontrolled sugars that you don't want to give it there, or and reason. Otherwise, for a bursitis, I would prefer to do a subacromial injection.
Because you are not having the fear of damaging the cuff further. That is the biggest concern with injections in the cuff.
Absolutely.
So in case you are anticipating a future repair or anything, I think the first step is to learn from Dr. Sharad how to give it. That is the first step.
The question is that the needle which we are using for the injection,
I'm using a spinal needle.
Just pierce once in the lung. How is going to cause the pneumothorax? Because it is a very small needle, it goes in and out.
Sir, having done a pneumothorax when I was doing for a central line in the neck, I am actually very paranoid about a pneumo. I have done one when I was taking the
because it is a big needle, but the injection needle is very small one. If it goes even in one prick in the lung, if you just
risk is less than 1%. It is less than 1%. It is possibly like if you are not trained enough and you make multiple punctures, probably you'll end up with a problem rather than
puncture. Obviously, there is a problem.
But it is like you teach gynae surgeons not to open the bladder. It's like teaching ortho guys, please don't puncture the lung. I think.
No. If you take any orthopedic surgeon that you are going to cause a pneumothorax, he will never inject.
So it is a relatively safe thing. All that I'm cautioning is that just get your anesthesia guys to show you like 15, 20 times to do it. And once you're confident that you have your needle placement in position, you can put a dye like we did to check that whether you're actually injecting in the correct place or not. So
Yes,
once you have that skill, I think it's not a problem.
Dr. Nitin now. Dr. Nitin, please.
Nitin, you want to say something?
Yeah, Dr. Sharad, I just have one question. What is the position of the patient when you are giving this block, and how difficult is to position the C-arm to get a proper view?
He is sitting position, he is told, na?
So
yeah, I know that, but how do you take a C-arm view in a sitting position?
So you have to move out of the field when the guy presses the C-arm. So you put the needle in, you leave it in that position, and you move out of the field while the C-arm takes a picture. So it's essentially a C, and the patient is like that in the center right there.
Okay, C-arm is in lateral position, like spine. Okay, Mukul, you were saying something?
Sir, actually, there is some literature. I am a student of Dr. Babulkar. He propagates he's a fan of ultrasound guided blocks. So he goes from the anterior, he puts his needle in the rotator interval, and there he injects the drug. He's not inside the joint, he's basically in the ligament, in the CHL. And there he pushes in the volume around 10 to 15 ml volume. And on table, he's almost on the examination couch, he's almost able to get a 20 degrees range. So does the range also improve in these suprascapular nerve blocks?
So once you give a suprascapular nerve block, and this we found out actually serendipitously because one of the guys, like an elderly guy with cuff tear, had not slept for 3 days, and he's crying in pain, and you do the block, and 10 minutes later he's showing you pictures of when he was like Mr. Punjab or stuff like that. So the relief in pain is often dramatic. It happens within a few minutes, and then you can get a relative who is nearby to teach them passive stretching. And often you find what was your finding initially, you improve a lot over it immediately because of the relief in pain. So all the stiffness may not essentially be sort of fiber stiffness, could be pain mediated as well.
I think that is a nice talk. And let's move on to the last talk of the day. Last but not the least, I wanted this to be a big one. 4-part fractures, everybody deals it. Sir, I would like to have the maximum input from the two stalwarts of Punjab Ortho Association, Dr. Sudhir and Dr. Hariom. Sir, in this, the proximal humerus fracture, I would like to have your comments and inputs on this case. So, Dr. Manat, please go ahead and let's see how does it go by.
Can you hear me?
Over to you, Manat. You are visible. And what about speak up?
He is
can you hear me now?
Yeah, Manish, this is all audible. No problem. Go ahead.
Okay, thank you. Thank you first, Dr. Siddharth, and the entire panel for giving me the chance to talk about 4-part proximal humerus fractures. And this is the most controversial topic of today. I know this. So hopefully, hopefully it'll be an entertaining talk. So this is a case that came... Nitin, can you...
I'm just muting him. I think he's... just go ahead. Manan, go ahead.
Yeah. So this is a case that came to us 1 month ago during COVID. It's a 67-year-old female. She had a fall at home. She came to us with a 4-part proximal humerus fracture. So what would be your management for this case? So this is how she presented a month ago during COVID times. And this is her CT scan. So I'll just show you the CT scan. Okay, so does your management change if I tell you that she had a DEXA of -3.2? We did an MRI which showed that there's a full thickness tear of the supraspinatus, a full thickness tear of the infraspinatus, and SC tendinosis. So your management prior to knowing this additional information, does that have any impact on the way that you would manage this patient? If yes, then why? And if no, why not? And I plan to make it interactive, but just for the purpose of this, it can just be a rhetorical question. So 4-part proximal humerus fracture. So it's the rule of 4s. We have 4 weapons in our arsenal. There's 4 pillars that drive decision-making, and there's 4 outcomes we wish to achieve. So the options for management are 4 weapons. The first weapon is non-operative treatment. Now, there are people that still do closed reduction with KYs, but it's become almost redundant in today's age. Intramedullary nailing, it has a high reoperation rate for 4-part fractures, so I haven't included it in this. The weapon 2 that we have is open reduction internal fixation with plating. Then there's hemiarthroplasty, total shoulders, which again are almost redundant now, and reverse shoulder arthroplasty. So what's the 4 pillars that whenever we see a fracture, the biggest mistake we make is we see an x-ray and we decide our treatment entirely based on the x-ray and the patient's age. But there's so many other factors that are involved in proximal humerus fractures, which we need to consider. And these are what I call the 4 pillars. So first is fracture combination. How many pieces are there and how bad are they? So what's the displacement? What's the number of pieces? The risk of ischemia. Is the head viable and will it continue to be viable? Biological age and local bone density. So we have to look at chronological age versus biological age. We have to look at local bone density in opposition to generalized bone density. And we also have to figure out in our minds mentally that will it support fixation, because that's really going to determine things. The other thing we need to look at is rotator cuff and arthritis. So is there an associated or pre-existing cuff tear? Is there any pre-existing glenoid and humeral wear? So what I do when the patient comes to me is that I take a thorough history. So I go back into their life and ask them that before you had this injury, before you had this fracture, what was your shoulder like before this? Did you have dull achy pains before this? Did you have any problems with abduction or movement of your shoulder before this? And that because most of these patients have never had an MRI or haven't had an ultrasound previously, they come to you just with a fracture. So those are important things to wean out in their history so that you can make a proper decision. So these are the 4 pillars that drive our decision making and hence the functional outcomes. So what are the 4 outcomes that I look for in my shoulder fracture patients? The first is I want to give them a painless shoulder. I don't want them coming back to me repeatedly with abhi pain ho raha hai, abhi pain ho raha hai. The second thing is good mobility and range of motion to ensure activities of daily living are not restricted. There's so many cases that come to us that have had plate fixation done at other centers, and they come and say, Dr. Saab, iske upar to kabhi gaya hi nahi. So that's again a thing that we want to look at. And the things that I want to achieve for my patients is I want to make sure they can comb their hair easily without any restriction, that they can do up their bra, and they can pull their wallet out of their pants. The other thing we really want to look at is implant survivorship. So that's a big outcome if you're going to use an implant, that will this implant survive given the age and chronological age and condition of the patient. And the last thing is fracture union. So if you are deciding to do non-operative treatment or open reduction, then fracture union plays an important role. And to an extent as well, hemis are included in this, and we'll talk about it. So all of these things can be assessed using validated outcome measures such as pain scores, function scores, union, and implant survivorship. So whenever we have a fracture patient that comes to us, we get our fellows. So we've got a fellowship program here. So we get all the fellows to take their constant and ASES score, and so that we can track them over time. So pillar 1 is fracture combination. So to understand fracture combination, you have to understand the deforming forces that are placed on the proximal humerus. The supraspinatus and the teres minor insert onto the GTN, they produce a posterior superior deformity. The SC inserts onto the lesser tuberosity and pushes it medially. The pec major inserts about 5 to 6 centimeters below the humeral head and deforms the humeral shaft medially. And the deltoid inserts onto the lateral humerus and takes it laterally. So this allows us to understand the biomechanics of fracture collapse. So you can see here the supraspinatus is pulling up, the teres minor and IS are pulling back. The SC is going to take that LT medially, and the pec major will shift the entire shaft medially. And these are the deforming forces on the humeral head. And this is how fractures deform. So when you see a fracture, it pretty much matches this. These are the deforming forces. So how do we quantify fracture combination? Well, we use NIAS classification, and we traditionally have for a long part of time. Now, there are some problems with NIAS classification. It's a 4-part classification that looks at the GT, the LT, the humeral head, and the humeral shaft. And he basically classified displacement as more than 1 centimeter of separation and more than 45 degrees of angulation. But there was no evidence basis for this. And there hasn't been any evidence basis for this since that time. So it's an arbitrary set value, and we've just been using it blindly. And one of the big problems with NIAS classification, it only has a moderate radar reliability. That means if there's 10 people, only about 6 or 7 of us will classify the fracture the same way. That means 3 to 4 people will look at a 4-part fracture and think it's a 3-part fracture. And the other 6 or 7 will consider it that, yes, it is a 4-part fracture. The good aspect, of course, of NIAS classification, it allows us to talk as surgeons amongst ourselves. It's very important for research. And it also has been shown that it correlates very strongly with outcomes. So the higher the near classification, the worse the outcome, and that's always been the case. And it also correlates very well with the rates of rotator cuff injury. So as the classification increases from stage 1 to stage 4, the incidence of associated rotator cuff pathology increases exponentially with it. The pillar 2 that we want to look at, and whenever we see a fracture, we have to see the vascularity of the humeral head. Is it a viable humeral head, and is it going to continue to be viable? So the anterior and the posterior branches are involved in the blood supply to the humeral head, as you can see on the image. So traditionally, we always believe that the anterior vessels, or the three sisters as we call them, that they were the most important part in supplying humeral head blood supply. But new cadaveric studies and new intra Doppler guided assessments have shown that it's actually the posterior circumflex humeral vessels which play a bigger role in supplying the blood supply to the humeral head. The arcuate artery is really important. So it's a terminal ascending branch of the ACA and enters the humeral head near the anatomical neck. So Hertel came out and said that Hertel looked at all these fractures and he tried to figure out that, which are the fractures which are really prone to ischemia. So he said that there's short calcar fragments if they're less than 8 millimeters, if they have a disrupted medial hinge, because that's where the vessels are entering. If there's anatomical neck involvement, again, because that's where the vessels enter. And if they're aged more than 50 years. So if there's any underlying vessels, so we know that as you get older, the amount of arteriolosclerosis in the vessels also increases. So you're more likely to have a poorer blood supply to begin with. So Hertel's data was actually taken and looked at long-term. And the results are really interesting because they found that 8 out of 10 patients who they believed were going to end up with ischemia actually did not go into humeral head collapse. And out of the 30 patients who he said that there's no way they can have ischemia, 4 of them ended up with ischemia. So there's more that's going on than just his criteria. So there's other factors that we're still trying to figure out as to what exactly does it. And if you look at the numbers, 8 and 4, so 50% were almost 33% of patients were actually missed that ended up in humeral head collapse. The third pillar we want to look at is bone density. So it's a predictor of your surgical reduction quality and screw cutout. And that's one of the main things that you see with almost all patients that come back with screw cutout is, I wish I'd done things differently. And all of that has happened to all of us. So generalized bone density measures, they're not accurate enough. We have to really assess the local bone density. There's no point of doing a DEXA scan, as I showed in the first slide. Even if the DEXA scan is minus 3.2, it does not tell me about the local bone quality at the site of the injury. And that's what I'm really interested in. So we have to assess that density with cortical bone thickness measurements on an AP radiograph. So we use Tingard measurements and the deltoid tuberosity index. And these are 2 simple measurements that you can do in almost any case of fracture that comes to you. And you can start doing them in your arthroscopy cases as well to see about osteoporosis. So the Tingard values, if they're less than 6, that's bad. And in the DTI, if it's less than 1.4, that's bad. And this is a slide that shows that. So again, we overlay our slides onto this and we're able to figure out what's the local bone density. The fourth pillar in our management is rotator cuff tears and arthritis. So we know that both cuff tears and osteoarthritis are associated with poorer outcomes post-fractures. The incidence of cuff tears, as everyone's talked about today, increases with age. So this is the MRI data. So 60% of 60-year-olds and 80% of 80-year-olds. And that's a really easy number to remember. So for fractures, we know that 40 to 50% of proximal humerus fractures have an associated cuff tear. And in 4-part fractures, 80% of them have a rotator cuff tear. So we really have to start looking more at rotator cuff tears. And as you know, as Dr. Samuel was saying, that he's part of AO, and AO has now said that soft tissues are in fact more important than fractures, and whether we should reclassify fractures as soft tissue injuries with an associated bone break. So again, with the shoulder, that statement is really paramount because the rotator cuff plays a big role in your outcomes and your function. And if you look at 4-part fracture dislocations, almost 100% of them, due to the way that the head falls down into that medial gutter, they do end up with a cuff tear. So we need to assess the cuff on the MRI. And again, it's not practical yet in India that we do an MRI for almost all patients that come in. But from where I learned in Australia and Professor Morel, they do it routinely now for all cases. So osteoarthritis is best assessed on a CT scan. So you're doing a CT anyway to look at the fracture displacement in a 4-part fracture. Also look at the glenoid. Don't ignore the glenoid because it's going to give you a good idea of what the glenoid wear is like. And it also helps you classify the glenoid according to the Walsh classification. So conservative management of 4-part fractures. So the new trend that's come about for conservative management has been 2 weeks of immobilization followed by passive mobilization. The traditional method was put them in 6 weeks and then gradually mobilize them. But now more and more studies are saying that you should do 2 weeks of immobilization and then slowly start with passive mobilization. The functional results are really poor. So conservatively managed fractures, if you do the UCLA score, the ASEA score, the constant score, functionally, they are very, very bad. And you'll be thinking that, oh my God, what have I done? But if you look at the patient, patients are really happy. One, they got to avoid surgery. The pain is really uncommon and patient satisfaction is through the roof. So they've done studies where they've looked at, looking at these patients down the line, how many of them are going to, so one of the questions that we incorporate into almost all our research papers now is that if you had to go through this process again, would you do it? One. And secondly, if you were to have a friend that was going to do it, would you ask them to do the same? So if you look at conservatively managed fractures, almost all patients advise themselves to have it again and their friends to have it again, to have conservative treatment also. So patient satisfaction with conservative treatment is really high. So despite low functional scores, pain's uncommon and patient satisfaction is high. So your patients are going to be really happy, even though that functionally they may not be that happy. So the PROFIT trial at 5 years, it showed no significant difference between operative and non-operative treatment for 4-part fractures. But the PROFIT trial has come into controversy because it was a really flawed trial design, and we won't go too much into that. So what about ORIF for 4-part fractures? So there's 3 key principles that exist for successful plating in ORIF, and these are 3 principles that you really need to adhere to if you want to do a good open reduction internal fixation with plating. The first and most paramount is you need to restore the medial calca. So through either a medial calca screw or using an endosteal bone graft, which we've started to do more and more in our practice now. You have to avoid having a varus reduction. So suture fixation of the tuberosities also plays a key role, but avoiding a varus malreduction of your fracture is associated with poor outcomes throughout the board. Valgus fractures, okay, but varus, no. And you need to prevent screw penetration, and that's where local bone density and doing a Tingard and DTI actually plays a big role in helping you decide that, is this patient going to be okay with an ORIF? Medial pillar. So the medial pillar has drawn immense amount of interest lately, and we're thinking of the medial pillar now as probably one of the most important parts of a shoulder fracture. So when you can either augment the medial pillar with some cement, you can put a graft, or you can do a screw. So valgus impacted fractures, once you reconstruct that medial pillar, you're automatically going to prevent varus malreduction. So once you've built up that medial pillar, the head cannot collapse into varus again. It can go into valgus if you've over-reduced it, but it can't collapse into varus. So randomized controlled trials have found superior outcomes when you put in a medial screw. And this is the calca screw. So your calca screw or your home run screw has to be really long and has to be able to hold up that medial support column. So in patients with poor bone quality, locking plates can be combined with a fibular strut graft. And that's what we're starting to do more and more now. So we're taking a little bit of the fibula, inserting it medially into that medial calca region to act as a medial strut and hence prevent the varus collapse. And the endosteal strut can also be used as a lateral augment. So if you've got some pieces, so you take a big strut, you use a little bit of it, you usually only need about 2 to 3 centimeters well impacted into the bone. So you end up with quite a bit remaining. So you can use that again to augment your lateral pillar as well. So the plate fixation, it has a higher risk of AVN secondary to periosteal stripping. So now there's newer plate designs that are trying to circumvent this problem. So whenever you're putting a big plate on to the lateral aspect, you are worried about periosteal stripping. So there's now angular stable plate that's come out. It's a S3 angular stable plate. And there's a radiolucent carbon fiber reinforced peak plate, which is this plate over here. So if you look at the X-ray, it looks like there's no plate at all because it's not visible on X-rays. So what about the data? So if we go into the literature and look at this, so for endosteal strut grafts, almost all studies now are showing that if you've got a fibular strut graft or an endosteal strut graft, in addition to your traditional plating, it actually improves outcomes. So outcomes are superior than plating alone. And the current evidence shows that there's a screw penetration rate of only 3.7% if you do it this way. So some trials have shown that there's no difference in outcomes for plating versus conservative treatment, whereas several studies have shown no difference in plating versus hemi. So this is a randomized controlled trial that looked at angular stable plate. And they found that there was no difference in functional outcomes between surgical treatment using an angular stable plate versus conservative treatment. Again, another study that looked at 3- and 4-part fractures, and they compared plating to hemis, and they found that ORIF leads to similar results as hemis. So what about arthroplasty for 4 parts? So the traditional indication for an arthroplasty in a 4-part fracture has been severe combination, concern for ischemia, and poor bone quality. So that's 3 of the 4 pillars. So now we've added that 4th pillar of rotator cuff. So the indications are expanding. So now we're looking at those 4 pillars, and if they're satisfying those 4 pillars, we're more inclined to go for an arthroplasty. So the GT and the LT have to be sutured around the implant and then onto the humeral cortex. And the good thing when you do an arthroplasty is that the head, you should always save it on the table because it can be used as a bone graft. So in hemis, the results have been mixed. It's always known that it's highly dependent on tuberosity healing. Also, there's an age-old atom here that increasing age, as you get older patients, they're more likely to have pre-existing cuff tears and more likely to have pre-existing arthritis. So the cuff is really important for the hemi to work, and tuberosity fixation is what drives the outcomes of a hemi. If you've got poor tuberosity fixation or a pre-existing cuff tear, your hemi is going to fail. So a functional cuff plus a good tuberosity reduction and fixation of the tuberosities is essential for your hemi to have a good functional outcome. And that's been proven across the board through literature. The biggest problem with hemis is that we often tend to lead to excessive lengthening and retroversion of the prosthesis. So often when people are putting them in, they're not actually seeing the version properly, and they end up retroverting it too much, which is associated with a poor outcome, because the more the retroversion, the more the external rotation, but you've also limited the internal rotation or the ability to reach behind the back. And that's one of the really important things for patients. So the more recent data on hemis shows that they actually have no superiority to non-operative treatment, which is really important. And the survivorship data is really important. And I want you to remember this as we go forward, is that at 10 years, hemis only have an 80% survivorship rate. You know what the survivorship rate for a reverse is at 10 years? 88%. So they're almost 8 to 10 units higher than a hemi. And the old thinking has always been that don't do a reverse because it won't survive 10 years. Well, then you shouldn't do a hemi because it's more likely to fail at 10 years than a reverse is. So if you look at a hemi versus non-operative for 4-part fractures at RCT, so they found really no big differences between the two groups. Again, a randomized controlled trial of hemis, and there was again no big difference when compared to non-operative treatment. So it really begs the question, is it worthwhile to do a hemi in today's age or not? And these are what hemis look like. Now, the really interesting thing that I want to talk about today, and this is something that we're doing much more of here in Chandigarh, is reverse shoulder arthroplasty. So it's the new kid on the block, and we're all falling in love slowly and surely with it. It's a primary procedure or secondary procedure for failed other methods. The outcomes of actually doing a primary reverse is much better. So if you do it in the first sitting, your functions are better, your scores are better. And if you do it as a secondary procedure, so someone that's got a failed ORIF, someone that's got a failed hemi, you want to convert them to a revision reverse, or a failed non-op that you want to take across to a reverse, the outcomes are actually much, much poorer. So it's better to do it in an initial sitting. So there are still a lot of issues that we're understanding with reverse, and implants have evolved over time. So it's not a debate that I want to get into too much, but there's debates around the core, which is the central rotation, and the version. And we discuss it on our groups all the time. So two big issues that have come up with reverse is there's been scapular notching and component loosening, which have led to poorer outcomes. Now, one big concern has been implant survivorship. So if you look at the systematic data, the survivorship rate at 10 years is 88%, which is still better at hemis. So there's been an old traditional thinking that, you know, hey, don't do a reverse, it's not going to last 10 years, but it's actually lasting better than your hemi is. So if that's your thinking for not doing a reverse and doing a hemi, maybe we're thinking wrong. Now, if we look at the implant survivorship data, again, that's what I was talking about. So 99% at 2 years and 88% at 10 years.
Yeah. Hello, Dr. Manit. Sorry to interrupt. Actually, Manit?
Hanji.
Got a reminder. Time we need to back up a bit because
I just finished quickly. So reverse, I'll just flick through this. So what does the data show? I'll just summarize this. So that reverse is superior to plate fixation at 2 years. That's a randomized control trial. That reverse, when compared to plating, reverse has been shown to be better than plating. Now, there's only one time. So reverse is better than hemi. Reverse is better than plating for certain fractures, but reverse is not better than non-operative treatment. You cannot beat non-operative treatment for shoulder fractures, even for 4-part fractures. Across the board, patients are happy. Even if they're not functionally happy, they are really, really happy with outcomes with non-operative treatment. So this was the first case, that case I was talking about initially. These are all the pieces that we took out of the head. So you can see the biceps tendon as well has been extracted. And this is the reverse that we did for the patient. This is the post-operative X-ray. And I just want to show you her 4 weeks movement. So she's now 4 weeks post surgery. So the video is not working. So I'll just show it on this. So this is her at 4 weeks. Remember, you cannot get this with plating. So this is her at 4 weeks post-surgery. And she's a really, really, really happy lady right now. She's pain-free and she's able to do about 60 to 70 degrees of abduction and 60 to 70 degrees of flexion. So in summary, 4-part proximal humerus fractures, we've got 4 weapons in our arsenal. There's 4 pillars of decision-making, 4 outcomes we want to achieve. Non-operative treatment is gold and you shouldn't change. Plating has good results for properly selected patients, and there are advances in plating that are coming, especially with regard to the medial calca. Hemi is now on the out. So if you're going to do an arthroplasty, you might as well do a reverse, and reverse is very much on the in. Thank you.
Hello.
Wonderful talk by Dr. Manish.
Sir, Dr. Sudhir and Dr. Hariom Aggarwal, sir, please.
Dr. Manish, it was a wonderful talk.
Okay. Thank you, sir. Thank you.
Hello. Oh, can you hear me?
Yes, sir. Can hear you.
So first of all, on behalf of Punjab Orthopaedic Association, I am grateful to all esteemed faculty and experienced panelists to give excellent talks and comments regarding shoulder arthroscopy. All through the webinar, I have been watching all the arthroscopic surgeons bubbling with their knowledge and coming out with their experiences. I think the webinars are the unique way to catch up with everyone and to pass on our knowledge to the youngsters. All participants must have gained a lot out of the tips and tricks provided by the experienced surgeon. Dr. Manish has given an excellent talk on the 4-part fracture of the proximal humerus. And again, a controversial topic, whether to conserve or operate. I think the condition to take decision in these cases depend upon the age of the patient, what is the demand of the patient, whether it is a high demanding patient, dominant limb, osteoporotic condition, as in this case, patient was having severe osteoporosis, and what was the preoperative range of motion of the shoulder at that time. In past, before the this arthroscopy and arthroplasty era became popular, we were just giving 2-3 weeks immobilization to these patients and later on mobilize the patient after 3 weeks. And these patients used to get the reasonable amount of the movement. And because most of the time union is not a problem in this case because the bone is a cancellous type of bone. So again, Dr. Manish has also given a good data that conservative treatment is also not bad. But yes, nowadays, because of the availability of the good implants, locking plates, osteosynthesis and arthroplasty can also be an option available to the patients depending on the financial condition of the patient and surgeon's capabilities. If the surgeon like Manish Arora, they are available to the patient, then these patients, they can go ahead for this type of procedure. Otherwise, we should give an option of conservative, non-operative or semi-operative like KVR fixation with the 2-3 weeks of immobilization, then rehab the patient to gain reasonable amount of movement so that she should be able to enjoy a good healthy life at this elderly age. Thank you very much. Thanks, sir.
Thank you, sir. Thank you. Dr. Sudhir, sir, comment on the case and the...
No, as far as the last lecture is concerned, I think Dr. Manit has explained very well. The only thing I probably disagree a little bit is that about the conservative treatment. It all depends what are the patient expectations and what he or she actually would put up with. Otherwise, if the fragments are displaced, you will always get a very poor function in these patients. But that is patient acceptance. So if we can do better, we should always try to do better. Like if bone quality is good, we can reconstruct it, probably internal fixation. Otherwise, both hemi or reverse shoulder, both options are there. And if the bone fragments are large, probably hemi would work as good as reverse. But if the bone tuberosities are very small, shattered into very small pieces, probably the reverse would work better in such cases, because that is virtually a rotator cuff deficient.
Hello. I think sir got disconnected, I think.
Yes, this is the problem because of the
So
sometimes the net
got...
gets disconnected.
Okay.
Siddharth?
Yes, sir.
Yeah, I just want to say one thing. So again, just to emphasize for everyone that non-operative treatment has brilliant outcomes. So even though functionally, if you look at it, they're not happy, but satisfaction and pain-wise, patients are really happy. So non-operative, as Dr. Hariom and Dr. Sudhir sir both were saying, it has really good outcomes for this.
I think Dr. Sudhir is back, sir.
Yeah. So no, I think I agree with them. But if like we are at the end of the session, so I would, on behalf of the Punjab Orthopaedic Association, I would like to congratulate Indian Arthroscopy Society for organizing such a wonderful program, and would like to congratulate all the speakers for very well presented talks, which addressed many issues. And so to you, Siddharth, also for arranging such a program where all the burning issues have been addressed. So once again, I thank you all for including Punjab Orthopaedic Association for such a wonderful program.
Thank you, Sudhir sir, and also my special thanks to Professor Aggarwal that that we could arrange this program with the guidance of my dear friend and junior brother like Siddharth, and also Rajnish was there. So we was trying to make this program for last 3 weeks. So it was ultimately possible. I could not understand how we have been totally engrossed for last 3 hours. Really, all the talks and the interaction was so good. So
it was wonderful, sir.
Wonderful. It was 3 hours. How the 3 hours passed ahead.
You're right.
We were looking at the clock. So it was so engrossing. And my special thanks to my take team, and who is the chief of the take team is Dr. Sandeep.
Hats off to Sandeep. He has put in really great efforts. Hats off to Sandeep. And
because he is the chief of the whole take team, and you will be happy to know that whatever the program we are doing from the Arthroscopy platform, it is all been archived. All the great men throughout the world, they have come into our meetings and already been in the IAS platform, and Sandeep has all arranged. Anytime you go into our website, you can see any of the lectures. Even today's meeting will be archived over there. So we are making programs with all the states, and also we have doing with our journals. Sometimes back, some good news are also been coming in the next few months. So I really convey my regards and special thanks to the whole team of the Punjab Orthopaedic Association, and my colleagues like Sharad is a very old friend of mine. So Sharad, special thanks to you even too. Thank you. Take care.
Thanks.
Dr. Sharad, don't teach your technique only to Dr. Samantha. Teach to everyone.